are you checking something, Adam?
No, we have people.
Okay. We have them unmuted. Any of our webinar participants, work group, can we have you tell us if you can hear us? James, are you out there?
James needs to enter his PIN.
Okay, James, we're waiting for you to enter your PIN. Okay, who else should we have?
Deb just put a message. She can hear us.
Deb, you can hear us. Fantastic. That is great news.
Her line is open.
Okay, Deb, can you say something? I see somebody talking.
She needs to unmute. Oh, you've got the bar up. Let's see. I do these all the time too.
Deb, can you hear us? Deb Tibbs. Okay.
We just can't hear her.
Okay. So.
Ask her to unmute.
Is she what?
She's on the computer.
Okay.
She must not be talking.
Oh, so
she's not maybe.
Okay. So is there anybody out there in webinar land who can hear us and who wants to say hello?
So we have Elizabeth who raised her hand.
James just came over.
James, are you there? If you can hear us, say something to us, please.
Yeah. Yes, I can hear you.
Is everyone unmuted?
Maybe they're dialed in on their computers as well, rather than.
I don't know. Liz Machado, are you there? Yeah, I don't know what's happening. Okay, you can type us messages and tell us what's going on, and maybe that'll help us have some insights about about what's happening. But we're glad you're out there anyways and you can hear us. We would really love for you to be able to participate with your voices. And in the absence of being able to participate with your voices, please send us messages frequently. Tell us what you're thinking and participate in this work group meeting. So thanks for joining us. So what I would like to do in kicking off this second meeting of the day, with some of you repeating the meeting, is just to start out because I think we all pretty much know each other, but why don't we just make sure that everybody who's on the line knows who we are and let's say who we're here representing, and maybe even some kind of a purpose statement if you can manage that. Something like, why are you here? Why did you participate in this group? What do you hope to get out of it? Something brief or lengthy if you would like. Okay, so I'm Denise Peach and I'm the chief of the CBAS branch here at CDA, and I'm here because I want to be and because I have to be. But I'm here to happily to kick off this effort that we've known has needed to get underway for some time since we did the last IPC, which was at the time of the transition from ADHD to CBAS. We did some work in a big hurry and we got it up and running, and that was the good thing. But I think we did some things at the time with the eligibility criteria that drive people crazy. We'd like to get that taken care of. And then just some things that were tabled in the way of issues from 2007 with the previous iteration when we did Senate Bill 1755 and we were putting reforms in place. And so we knew we had some issues to fix in the IPC way back then, but of course we weren't going to take care of those during the ADHD to CBAS transition. Too much to take on. So happy to be here working on some things that need to be developed, just the sort of the minor things with regards to the format and tweaking, but also taking on the bigger discussions about personnel planning and all the implications. So happy to be here working on this today. Next.
Jill Sparrow, I'm one of the managers with the CBAS unit here at CDA, and I, of course, I'm very happy to be here as well. I'm fairly new to the CBAS unit, and so I'm here really just kind of get up to speed on the work of these two groups, and I just take in a little bit all the information that's being presented today. So.
I'm Dawn Myers-Perkey, and I'm from YOLO Adult Day Health Center, and I have been the bulk of my career has been about adult day health care, pushing 20 years, and I love it and have watched it grow, and I've grown, and I am anxious to see the IPC turn into a document that reflects what we do as a center and not all the regulatory checkoff stuff, and have it really enhance the IDT and the whole process that is around folks coming into the center. So, and I love seeing all you guys. So it's nice to get that opportunity to interact with the people who inspired me throughout my career.
I'm Amanda Stillers, and I'm with Total Adult Day Healthcare Solutions, and I'm here because
person-centered care and the clinical aspect of person-centered care is I'm fascinated by it. I love it. I love that it's effective, that it really, really works. And I find it such a beautiful way of working with the elderly and working with anybody, and so much more humanistic and even more effective. The IPC has always fascinated me from the moment we started, and I started about 17 years ago. And in every time it's changed up, I've had ideas and thoughts, and I'm about creating efficiency and increasing effectiveness of our staff, because I think that when there's so much paperwork to be done, that we lose the ability to work, the time to work with our participants, which is really what we're here for and what we do. So that's kind of my hope and my reason for being here. Is I'm extremely passionate about adult day services, for one, and two, that if we can improve our documentation and improve our care, then that's just the epitome of what we want to do. That's why I'm here.
I'm Lydia Miscellanies, and I'm the Executive Director for CADS, California Association for Adult Day Services, for a long time. And I'm here because I want to support this effort and support all of you guys who really do the hard work, just as Denise and Jill and Lilith are here to support the efforts on behalf of the participants and their caregivers. And I share the same goals that have already been expressed about trying to think about this tool as being more appropriate for the outcomes that we're trying to achieve. So I'm looking forward to it.
My name is Amanda Puccina, and I manage Anthem's CBAS program for the Northern region. And I'm here for a couple of reasons. One, I think as a clinician, I recognize the value of CBAS. And then working for the managed care company, it's interesting to see the evolution of CBAS in general as a benefit, and the evolution, I suppose, of us working together, since it's only about 2 years old, I guess, since people have been in managed care, or at least since CBAS has been,
Right.
yeah. Just to see how we can work together and how we can improve.
Right.
I'm Selena Escobar, a manager with HealthNet Public Programs Department, having to oversee our oversight monitoring of CBAS centers statewide. Really my purpose here is to work with both work groups, quality and the IPC work group, and to partner with you all and the CBAS centers to see how we at HealthNet can come up with some better, innovative ways in partnering with you to help improve coordination of care, person-centered care. I'm thinking of, the IPCs and how they are shared and transmitted from the centers to the health plans, and moving towards an electronic way of continuing to do that. So it's an exciting opportunity to also be here in person. I mentioned during our lunch break that at least I don't get to see you all in person very often, so this is a good way to network and stay involved as well.
Kate Huddleston from Golden Umbrella in Reading, Adult Day Healthcare. And as I told Denise when I got here, is I didn't want any surprises when a new IPC came out. I want to be ready for it. Plus, I want to give my input for our Adult Day Healthcares and how important the IPC is in providing good care planning.
I'm Diane Puckett, and I'm the Executive Director of the Peg Taylor Center for Adult Day Healthcare up in Chico. And I've been through a lot of IPC.
Yeah, me too.
I don't want to miss this one. Because as I think it was Lydia that said, you all have expressed so well, there's so many firsts happening here. I think, quality has always been a part of the conversation at some level. But this is the first time that we started our IPC revision with a whole discussion of what quality is about, and with so much to inform it that's going on nationally in our state, so much leadership present, and the ability to work closely with our managed care partners and to really look at this as a living document that represents ultimately
a documentation of hopefully the very best care being provided in our CBAS centers for our participants. And the other reason that I'm here is because I do see today I don't have to prepare the final IPC that gets submitted. I see the extent of the effort that goes into preparing that document, and I do think that some of that is time that we could be using to work directly with the participants. Our program directors today have a huge job to prepare these IPCs and submit them, and we're loving the timeliness of everything, working with managed care, and that's been a wonderful development in terms of kind of working in real time together. That's improved because of the management and the coordination together. So if we could also improve that other side of things, then I think that is time then that can really go to looking at outcomes and measuring those and carrying forward a lot of things that we've all wanted to do for a long, long time.
We're doing introductions.
Okay, I'm sending an email to folks because some had trouble getting back on to the webinar. So Lynn Benjamin, Health Program Specialist, CBAS. Thank you all for being here again.
And I'm Lila Tomasian. I'm one of the managers here at CBAS, and I'm very happy to be here representing CDA in this very important effort. And we do have an introduction from online.
Fantastic.
So we have Tatiana Orozco from Anthem. She's an RN and case manager working at the CBAS department.
Tatiana, welcome. Thank you for joining us. Anybody else out there in internet land that wants to introduce themselves? That would be great. And meanwhile, and Adam Smith is in the back of the house from CDA rocking the webinar. As always. Thanks, Adam, for your help. Okay, so let's get going. A couple things. Let's go over the agenda for starters. That I forgot to mention this morning that in our scheduling efforts, one of the things that we that always happens, frankly, is that there's always somebody who can't come, and our DHCS partner in this is Rebecca Shoup. Actually has an all-day meeting downtown with the MSSP program, and so we kind of somehow managed to overlook that in our scheduling efforts. So DHCS has been participating with us in this effort, and managed care. Who was here represented by Oksana this morning, so we'll make sure that we don't do that at the future meetings and that we have DHCS sitting at the table, because that's a very important part of this this whole discussion. And we make sure we're all going forward hand in hand together. So that's one of the joys of this effort. So on the agenda, the top of the agenda, the welcome and introductions, which we just did. And again, we still welcome any more introductions from the webinar, people out there who want to introduce themselves. So let's go over the agenda. We're going to do, as we did this morning, a little review of our charters and the sort of deliverables from this work group, what the expectations are. We'll do a little background through reviewing the waiver, 1115 waiver, special terms and conditions that are governing some of the need for this redoing of the IPC. And then we're going to take a deeper dive walkthrough of the IPC itself. So we look at sort of the anatomy of the current IPC as we start going forward and talking about what we want to do and not do to it. We'll have some remarks by Amanda and remarks by Lydia to sort of help kick off our discussion about what we want to consider doing. And then we'll again we'll talk about some of the overlap, and we'll look at the end of the meeting some suggestions for some ad hoc activities in between our work group meetings to see if we can knock out some of the work products here a little faster. My hope, actually, this work group is scheduled to go through June of 2016. My hope is that we can do this faster. I think that we might be able to, especially leveraging it off of the work that's going on in the quality group. Not sure, but I'm hopeful that we can. So with some between work, and I think we have some suggestions for some between work group starting points for activities, ad hoc activities. So that's what's on the agenda for today, and then of course anything else that spontaneously comes up is on the agenda. Because this is a work group meeting, not a presentation today. So So that's what we have planned. Objectives for today's meeting really are just to get the work of this work group started, provide any necessary background we need to get moving, and to, I hope, walk away with a game plan for what we're going to do between meetings. I think we're positioned to do that today. Anybody else? Any other objectives for today? Okay. And another objective is that we get all of you talking. Okay, that's my hope. So let's go to the work group charter. This actually has a draft water stamp on it. We can't read it through this screen, but we want to take that draft off of this today, just like we are going to do with the quality work group one, and make this our the for sure charter. We drafted this some months ago, so I want to make sure that everybody's still in agreement with it. Much of what is on here in the way of the purpose of this work group actually came out of what we have on our future topics and parking lot issues that's posted on our website that we talked about way back when we were renewing the waiver. So we had been talking about wanting to do this, and then this is now married up with some of our new mandates for person-centered planning that came down from the feds. So part of what we're chartered with here is to support the person-centered planning. So we're going to develop this IPC or the revisions to support person-centered planning, bring the IPC up to date with current program requirements, facilitate information exchange between CBAS providers and managed care plans for treatment authorization and service coordination, increase capacity for documenting, tracking, measuring beneficiary clinical data, quality indicators and outcomes, and improve the form's design, functionality, and ease of use. So that should be enough that we're charged with doing. But if there's anything that anybody else wants to sort of add to the list, now's the time, because we're going to take that draft watermark off. Also, if there are people's names that are listed here that as the work group members who are no longer going to participate, or we need to switch names for somebody, please let us know, and we'll change that out as well. And then also just stating again that if anybody wants to join this group, this is not a closed group. We just want to make sure that anybody who wants to participate is willing to attend and participate on an ongoing basis and contribute. So welcome any latecomers to the effort. Scrolling down, there's some background about the IPC and how we, at the time of the elimination, I mentioned earlier that we made some minimal changes and that there were other things that needed to be addressed. And then through the stakeholder process and the amendment of the CBAS waiver provisions, then we got some new mandates, some new marching orders from CMS because of the Affordable Care Act person-centered planning requirements that are in the regulations. So now we've got this new stuff that we need to get working on. So that's a little bit of background. And then just we kick this thing off in July. We actually have a 12-month period, but we can get done soon. That's great. Okay, everybody good with it? Great. Yes, Diana.
If this goes forward as our charter,
yes.
I know that the intent of saying the elimination of the adult day health care program is as a Medi-Cal benefit, but I just wanted to make note and request, as I have so often,
yeah.
Could we say that a little bit differently? Because when people get this information out of context, they think that our centers have gone away.
Okay, so elimination of the adult day health care program as a Medi-Cal benefit.
Well, and it's, or some other way even of phrasing that, because it's a conversion to the CBAS or benefit.
Yeah.
Because
well, the adult day health care is the license, and so we technically the adult day health care is not a benefit anymore, but I don't care how we say it. Let's just say it the most politic way. So what we don't want is anybody to think you're not there. So the suggested way, concurrent with the transition of adult day health care program to CBAS as a Medi-Cal
of the adult day health care Medi-Cal benefit into CBAS.
Okay. That's a great, thank you.
We'll do it and send it out to everyone.
Yeah. Yeah, you know, Diana, you brought that up before. I should already have that.
No, I appreciate it.
Yeah, it's important to
And then Denise, should part of our charter, this is Lydia, also be that we will, or is it, maybe I should pose it as a question, is part of the charter of this work group to also think about a training and rollout?
I don't know. Let's talk about that. I mean, I think that we listed that in our HCB settings transition plan because we have we have stated that we were going to revise the IPC and we were going to put the person-centered planning stuff in there. We said we built in training for the new IPC. So, so that's already on the calendar. So if you guys are willing to help us with anticipating that and making suggestions, and I think that would be a great thing to add. So maybe it's under purpose to number 6. Let's just say that we say assist with planning rollout of the new IPC, including training.
Yeah.
You have some wording on the quality purpose as well related to training, CBAS staff training on best practice. I mean, there's some.
Okay, it's on the quality.
On the quality.
Okay. Okay, we'll check with that. Okay, I think it's a great suggestion.
Because you've got the plans here.
Yeah, you guys are willing to help with, brainstorming that. Yeah.
And the, if we could make that inclusive of all parties who are engaged in this. So I think rather than just CBAS staff, it's really, we need to train around the universe.
Yeah. I just said this is a rollout of the IPC and IPC and training.
Yeah.
So the training would be included.
Oh, I was looking at the CBAS staff training of best practices and quality improvement. Right. The number 3 that I think you were referring to.
Okay. So we'll just make sure that that's
General
plans.
Yeah.
Plans and providers. Great.
We're in it.
Love the joint training idea. And I'll just tell you, over the last couple of years since we've been doing, webinars, whenever we have some, there's managed care plans almost always jumping on our training on some of the funny subjects too. We're doing the new participant characteristics report, and the plans are jumping on our training. So it's great to have them, and anything they want to learn about what we're talking about, they're welcome. So.
And I'm thinking regulators too, because even during our CBAS certification reviews, that's important that we all have.
Our staff, always
up to date.
Yeah, plans are coming more and more to our conferences, and we had one plan in Northern Cal sponsor their centers to go to person-centered care, and also in Southern Cal, HP sponsored 11 providers to attend. So I'm just really feeling like we're still, we're kind of past the implementation phase now, and everyone's kind of into a routine, but now it's time to raise the bar again, and I see the plans really wanting to support that and support quality and understand it, and that's been really exciting.
Great suggestions. Okay, so we're going to modify the charter. I made a bunch of notes, and the training piece, that's great. If you guys want to help with that, you're welcome.
Any comments from those on the webinar about the
anybody out on the webinar that wants to add any suggestions around the charter?
Let's give them a minute.
Yeah, we'll give you a minute. We'll keep going a little bit here, but if you have any suggestions, we'll come back to them. We'll read them out. Okay, great. So let's talk about
the regs.
What? What are we looking for?
I'm pulling up the regs.
So let's pull up the STC 96 and then the federal regulations.
Is that the same handout as the morning, right?
It's the same handout
as the morning.
I thought it was. Okay, so just to give, again, some background, we talked about this during our July kickoff. And so what you need to know, if you could scroll down a little bit further there, we want to look at STC 96. So for review, the 1115 Bridge to Reform demonstration waiver that includes all of the stuff that is of the demonstration also includes provisions for CBAS and CBAS as a Medi-Cal managed care benefit. The special terms and conditions, otherwise known as STCs, are the basic, they're breakdowns of the different rules that are in the waiver for CBAS. So under IPC, which was in the previous waiver, it got amended when we did this last time, and CMS put some new stuff in under IPC, a bunch of new stuff. So what they said was they had already said we were going to be doing this home and community-based settings work and doing a stakeholder process to develop a plan for transitioning and meeting all those federal regs. But they also put in here under the IPC, well, through that stakeholder process, we want to make sure that you develop a plan for ensuring that your person-centered planning that goes on in your CBAS centers also meets the new federal regulations under the ACA and elaborated on Affordable Care Act and elaborated on through the home and community-based settings rules. So, so they tucked this stuff in. So, to read it to you, so basically they said that, that through this stakeholder process that we were going to complete by September 1, which we did, we were going to include information about how our plan, and that's our plan, our person-centered plan, not the managed care plan, will identify each enrollee's preferences, choices, and abilities, and the strategies to address those preferences, choices, and abilities. How the plan will allow the enrollee to participate fully in treatment or service planning, discussion, or meeting, including the opportunity to involve family and friends and professionals of the enrollee's choosing. How the plan will ensure that the enrollee has informed choices about treatment and service decisions, and how the planning process will be collaborative, recurring, and involve an ongoing commitment to the enrollee. So that, in a nutshell, really is a summary of what's in the federal regulations for person-centered planning. So it's now in our CBAS provisions of the waiver. Oh, I have a little laser at some point I lost it. Oh, there it is. So if you scroll down a little bit there, and then there's some more information about the plan, the IPC. Some of this was in the previous version, but then they inserted some more information about person-centered planning. It includes consideration of current, unique, biosocial, psychosocial, cultural, and medical needs and history of the individual, as well as person's functional level, support system and continuum of care needs. CBAS Center, the beneficiary and his or her support team shall review and update the IPC at least every 6 months. Blah, blah, blah. That's all a repeat of what we already have in our regulations, except for the beneficiary and their caregivers have to be involved. And then there has to be a discussion about the progress toward goals and objectives, which is not in our current version of the IPC. And then there's all the elements that have been in regulation for a long time about what needs to be in the IPC. So sort of just a jump ahead on this. One of the things that we anticipate doing for probably before the next meeting is that we will have a inventory of all of the things that actually we have that sort of in our tool right now of what the feds are saying we need to put into this IPC, and then so what things that where we have it, if we currently have something like it, what we need to change, how we need to adjust the IPC to meet these requirements. So part of our exercise really is very straightforward. It's going to be a crosswalk of what they're telling us we have to do, and whether we have already got it built into the IPC, and if we don't, where we want to put it. So that's just a little bit of a look ahead. And then the other reference that we have here, and we'll put all these documents on the website for everybody to look at as well. Let's take a look at the Affordable Care Act requirements for person-centered planning.
Yeah.
And I highlighted these again during the July kickoff, but just to reiterate, the Affordable Care Act regulations, and here are the here's that STC 96, those 4 points that I just, and then here's the actual federal regulations, 42 CFR 441.301, and it says, it basically lays out all the specifics of the federal government's expectations around person-centered planning process, the person-centered plan itself, and then the revisiting of the plan or the renewal of the plan, which is the simplest part. It's just basically that you have to, upon reassessment, you have to, it has to happen at least every 12 months, and for us it happens every 6 months, that you have to revise this with the participation of the participants. So again, I don't want to spend a bunch of time on the federal regulations today. We'll put you all to sleep this afternoon, but just so you know, there are really specific marching orders that we've been given around the process for person-centered planning, the plan itself, and then renewal of the plan, so that we have to, as we go through this IPC revision, we have to consider all of these things. And then,
Denise, can I jump?
Yeah, jump in.
Question. Go ahead.
This is the review, so just,
Did you have CC 441? See it? What is it?
it's on your agenda, 441.301, little letter C, 1 through 3. So what we've done, we actually put this in just a basic Word document because the Federal Register puts them in 3 columns.
Did you have it up there a minute ago?
It's really hard to read.
Oh,
Federal
this
Register.
one? Yeah, we have a copy over there.
Can we go back to it is what I wanted, so that I could.
Which, not this document, a different one?
The person-centered federal requirements.
Right.
Yeah, that's this,
Right. So it's in our CBAS requirements.
in the waiver.
here by reference, right?
96C.
Yeah, so you just went, and I remember originally we didn't know what this was, we were trying to find it. And so I just wanted to look at it again, because this is not, this is not a CBAS provision of this waiver. This provision is incorporated within our CBAS standards.
So it is a CBAS provision. STC 96C is specifically talking about CBAS. And what CMS told us.
But no, what I'm wondering is, where does that originate? It doesn't originate with the STCs for CBAS, right? It originates elsewhere.
Is this the HCB?
So the document that we just had, okay, this is our waiver document, and our waiver document for CBAS includes STC 96.
But that was a standard that started elsewhere.
That was a standard that.
No, I mean not 96. This other one. I'm sorry.
So the Affordable Care Act has started the person-centered planning regulations,
right.
and then the home and community-based said
441 starts with the Affordable Care Act.
That's right. That's where it started.
Right. So that's actually the point that I'm trying to make, because, and the reason I think it's important is because of the language and trying to discern what the language is actually saying to us about how we need to work with our participants and with our IPC. So that's why I wanted to go back to it a minute, because I think if we can keep that really clear, there is this federal provision, then we're being asked to do something relative to that federal provision, but that federal provision starts elsewhere, so it's not specifically a CBAS standard. It's a federal standard that is referenced in our CBAS requirements.
Right.
And so now we have to figure out what it means relative to our CBAS programs.
Absolutely, and I guess I would say that, yeah, it is global,
really
and
clear
it's
here.
not even just for the home and community-based centers. It's a separate definition of person-centered.
Well, and that's what, that was actually my question as well, is that, so this one that's titled Person-Centered Planning Federal is what we're talking about, not that. We're talking about the Person-Centered Planning Federal Requirements document. It's a separate 2-page document on the handouts.
So the person-centered federal requirements are included in this right here.
Yeah, Lynn, I was looking at this document though, the 2-pager that spells out the federal requirements.
But then where does she go?
There's another document.
That's that one.
That's more than 2 pages, so it's
That's a 4-page.
it's a 4-page, so I'm
Well,
not sure which one we have.
We only have two.
Oh, okay, then that's
That's why we're confused.
Okay, sorry. Now we're figuring it out.
Apologies.
Okay.
All right, so anyway, so going to that, yeah, that one, stop there. Hang on. We're just missing 2 of the 4 pages. Anyway, the point being, to Diane's point, this is broader than CBAS.
Yes.
This is feds going down to the whole nation,
Yes.
defining person-centered. The point, and I think Diane's making, and I was thinking in my mind relative to our health plan partners is, does this apply as well to how the health plans develop their care plans for people that are on CalMedi Connect or other individuals?
Yeah, that's a question I'm not qualified to answer.
I don't know. We have a separate team that does the LTSS.
Because I think we need the answer to that, because I could see where some of these relate to a larger level service plan.
Yes.
It should be a health plan or a regional center level,
Right.
I'd say, California Regional Center.
Yeah.
They're developing a service plan, and then that directs care to particular providers who are going to implement the service plan along with the beneficiary. And some of these seem to relate more to that higher level global plan than they do to our IPC. So if we can, like you said, discern, and maybe we can go back, and you could do the same, Selena, and we can get clarity on how much of this is a mandate for the plans. Maybe it isn't, maybe it is. Then I think that also helps us figure out what's their role and what's our role. And we don't go like that.
Right.
And this may be throwing mud into the water, but there's nothing on this, especially on number 2, that looks like it's something that we couldn't do, that wouldn't apply. There's nothing that I see that, from what I've thought about on person-centered care, that wouldn't apply to us as as a work group.
No, that may be, but I'm just thinking we want to be sure that we're not working across purposes with others who also have the same mandate for the same beneficiary. That's all I'm saying.
And there are
Let's be
some
clear.
other
Oh, so you're thinking
implications
maybe
for person-centered care that I have concerns for. So, what Lydia's describing that, that's the starting point in my mind, and then you come all the way down to the individual. And then looking at that individual, do they actually have a need for a service plan, kind of plan? A plan of care, what we're doing in our centers, the treatments we provide, that kind of thing, may not be the same as a service plan. We need to be sure that we're understanding.
As far as I understand, and I don't work, we have a separate team who does LTSS specifically.
Yeah.
I was just going to say, this does look a lot like the APL 1410.
Oh, okay.
The
I've got all those
MLTSS care coordination requirements. There's a lot of the same language, so
That's what I was wondering.
And this, I'll just tell you, has been a conversation mainstay among the group that's been working on the statewide transition plan for home and community-based services.
Okay.
Because everybody has the same kinds of questions. Which plan are we talking about? So the regional centers, are we talking about the regional centers plan or, or the managed care plans plan? And I guess I would just say in my experience with this is that so far I haven't gotten much clarification on that. So what we keep coming back to is what CMS said we must do. And that's those first 4 things in the IPC, in the IPC 96C. And if you could bring that back up, the 96C, those 4 pieces, or actually it's in this document, just scroll up to the top. And then also what's a little bit later in 96C. So they say we have to be talking about how our plan will identify each enrollee's preferences, choices, and abilities, strategies to address the preferences, choices, and abilities. So that's a directive for CBAS, as is, and allowing so as part of the process, allowing the participant to get involved, as well as any family members or anything else they designate, ensuring that they have informed choices about their treatment and their service decisions, and then being collaborative and recurring on an ongoing commitment to the enrollees. So they laid those out as specific CBAS requirements. And then if you go, can you pull up 96C again? And then there's the piece about what has to be included in the plan, which is go up a little bit. It's right here where I was pointing out where they said this is just for CBAS, that the person-centered planning includes consideration of current unique biosocial, cultural, medical needs and history of the individual, person's functional level, support systems, continuum of care needs. So again, they've given us some specific directives for CBAS as well as the overarching ACA rules. So, but we'll do our best to get some more insight about that.
Together, so everyone, we do actually have all 4 pages.
The documents I sent out last night has this attachment.
And
so
is the concern about this person-centered service plan, what CBAS and what the managed care companies will do, is so that, would part of our charter perhaps be determining, what is the managed care role and what is the, managed care is going to write certainly managed care is going to have a plan of care for the participants, a service plan for the participants, just as we will. And I think on one of the either it was a work group or something we did, one of my suggestions is that you are going to have overreaching goals, I would expect. The managed care companies are going to have overreaching goals. We will have, the CBAS centers will have actually defined them as a type of specific the interventions that we're going to do to help you reach those overreaching goals, but we're not going to get cross purposes. You're not going to say we want to lower blood pressure, and we're going to say we want to raise blood pressure to be facetious. And that's kind of what I'm seeing is I don't see this. That's why I'm not seeing a confusion between whether these are federal and apply to us or.
Right. I think I'm assuming, I don't know, but I think that I'm assuming that the LTSS requirements for their care plan that the managed care plan does, I would think that would be at a much higher level, and it would include helping to organize and arrange services for the member.
To help them meet the identified goals that are person-centered based.
Yes.
And one of those interventions that you would be providing is CBAS.
Exactly.
Exactly. This IPC is a huge part of that, though. So when we receive the IPCs, every 6 months, we share that with our either internal case managers or the PPG case managers, so that they know, how to appropriately work with these members and also to develop that larger.
So that even gives you more information about your own. So for us to take on this second, the person-centered service plan, the federal actually helps support the managed care companies, as opposed to saying this, this might fall under their purview and this would fall under ours. If we take, and I've thought about this, if we take this on, as well as whatever yours is, we're actually supporting you, in effect.
So to come back to Diane's, maybe your concern, and I think we can address this by doing the inventory that I was talking about before, is that we look at them item by item. Today, I'm just sort of giving this as background to the conversation, but we can look at each one of those things that the process is defined as in the Affordable Care Act rules and the plan, and we can see if there are areas where we feel like that absolutely goes beyond the scope of CBAS, then we can look at getting some answers about whether that goes outside to the managed care fund responsibility or something.
Yeah, I mean, there's 2 examples on page 2 right off the top. Offers informed choices regarding services and supports they receive and from whom.
Right.
The plan could be doing that, and they do, or maybe
Where
we're
are
doing
you?
on page 2. I'm on the federal, the handout that was the 4-page handout, which we actually have all 4 pages up. And then records the alternative home and community-based settings that were considered by the individual.
Right.
So was the plan going to do that, and then we're going to do that? No.
Right.
That doesn't need to happen. So that there is overlap here.
Yeah.
So once you do that drill down exercise, we'll see if
Yeah, I think we'll walk through all of them. And again, this is one of those things we can do the HCB settings discussions. We've talked about, well, we know there has to be an assurance of this. How do we manage this? So are we going to hold the CBAS provider responsible for actually doing it, or are we going to talk to them about whether their processes have identified that it's been done? This has been a little bit of a swirly area for us.
Right. So trying to clearly understand it, and everybody's articulated all of that really well. And then down to the person-centered level, part of what I'm thinking about when I think about working with families and individuals in our center is that not everybody does not need the same level of service planning. And care planning is a different aspect. So they all need care planning in the center, but they may not need care management. The individual may be care managing for themselves. They may have a very competent caregiver who's doing it. And so that's partly why I wanted to look at that clearly, so that if we look all the way back to the federal standard, we can define it's the right care, it's the right services, at the right time, in the right way, at the right level. And that's what we're achieving. So that we are still meeting that federal standard for no matter how independent people are or how much need they might have for support in these areas.
Right. Okay, we'll go back over that. Willa was waving her hand. Did she have somebody saying something?
Yeah, we have a comment from Bob Ariel. So a fundamental shift to a person-centered planning can or should we consider circle of support in place of multidisciplinary team. Circle of support concept is a shift in control from clinical to personal. Expands and shifts sphere of influence in the PCP. Circle of support is a fundamental concept to PCP. PCP is not necessarily prepared by the center, but more with the person and their circle of input. Amanda Sillers, please chime in.
I think we're actually going to be getting into that when we do the walkthrough. So.
Can we open this mic? Bob, is there any way we can open your mic? Open.
Bob, can you speak with us? I don't know why we're having such difficulty. Okay, so here's what we'll do. To keep this moving, because we're still in the introductory phase here. We've got an inventory tool. It's a great point. We'll make sure that we walk through all of those things and make sure that the federal regs and what we understand to be our CBAS role, we're all in alignment here.
Okay, so the conversation, we may then tweak what's in here in terms of it might just be in a document or health record, but it might be with the plan
Right, exactly. And I think that was to Bob's point. Thank you, Bob. And we're going to talk a little bit more about that as we get into the walkthrough of the IPC. So what we've got up on the screen,
No, what do you want?
what the tool, the work tool.
Oh, you want to go back?
Yeah.
to that?
Yeah, I don't want to,
Okay.
let's not talk about show notes
Oh,
anymore.
okay. But these are the regs in a different
Yes, they are.
format.
It's a little bit different format. This is a work tool we attempted to get up and running with here because we know we need to do this inventory. So this is what I mentioned earlier that, so we've got, if you look up in the upper left-hand corner, federal directive or requirement, and then we've got listed what it is. These are the waiver and the 42 CFR. And so here's the CBAS waiver, and then we walk through those 4 criteria. And then the header up at the top here says that, so we're going to look across and we're going to say, okay, for this one, how does the plan ensure that the enrollee has informed choices about treatment and service decisions? And then, does this require an IPC revision? If yes, where, what, and where? Again, this is just a preliminary idea at a tool for how do we sort of identify this. And then let's just say we say no, it doesn't belong in the IPC. But is there another document that we want to revise related to this? And this goes to the heart of one of my sort of pet issues with this project is that I feel like my hope is that part of what we identify as we go is the supporting changes that might need to be put in place alongside this IPC, not to make more work for you, maybe even make less. That if we think about right now in CBAS, ADHC ready to say that we have to have a participation agreement. Is there an opportunity to consolidate the participation agreement into the IPC as part of this set of changes? Would that make sense? Or maybe separately, do we want to look at just standardizing a participation agreement that incorporates some of these requirements and we knock off some of the person-centered requirements via the participation agreement? So I'm hoping that as we talk about this, we don't just go, oh no, there's no change needed to the IPC, and then we just move on. But we think about, are there other implications for processes that we are required to do in ADHC that we should consider looking at here with a change? So again, just a sort of a placeholder that as we go through and do this inventory, that we find ways to loop in other processes that support person-centered planning, that support MDT process, et cetera. Okay, so this was just again a draft of a tool. If you guys have any good ideas as we go along through the conversation today or afterwards, we can talk about this as a something that we complete going forward. Okay, all right, cool. Okay, so that's about enough on that subject. So let's are we ready to do the walkthrough of the IPC?
Oh, yeah. I'm trying to
Yeah, let's do that.
I know we are.
Let's do that. But before we start actually doing the anatomy of the current IPC, let's let somebody else talk for a while. We've got Amanda, who had some opening comments that she shared with me and Lynn in some conversations. We had some electrifying conversations before this work group that she wanted to share. And I think she's got something, I think a little handout template that will help us understand some basic things before we get started. And then Lydia will make some opening comments as well. Let's do that. Somebody else talk.
Okay.
Yeah.
Okay. So my thought process on this was, and just know this is black and white. This is not like all medical is this way and all person-centered is this way. I created a real kind of a black and white grid just to get us kind of on the same page. What I wanted to do is, as we go forward, if we're all kind of on the same page as to the theories of the person-centered care model from a clinical standpoint, I thought it would make it easier if we agree to it, and we can have conversation about it however it goes. This was taken from a lot of, I can't name everything that I read in the past 3 or 4 years and researching this for the books and all that. You know, the stuff goes into my head in concepts. So it's been pulled from a lot of different information. These 3 articles below are pretty interesting and give you some overview of where some of the information is. But I have lots more if you guys want to put yourself to sleep before you go to bed. So basically, the medical, it's comparing and contrasting the medical model, how when medicine and I might blow this, but basically as medicine became more, I would say I'm not going to go there. The medical model emerged as we became very good with our medicines, basically. And what doctors were doing is we treat individual diagnoses, and we became very good at treating individual diagnoses and getting away from the view of the whole person. So person-centered care is really about viewing the entire person. as opposed to treating individual medical diagnoses. So care, and it's, so just looking at the basics, the medical model is hierarchical, where the person-centered model is team-based. And we know that, you know, California is it's very team-based. We have a multidisciplinary team. It's an incredible multidisciplinary team. You guys have heard the story before when I found adult day healthcare after working in a nursing home and some other geriatric medical facilities. I fell in love. I fell in love in reading the regulations, which might sound banana, but I did. And the angels sang, and I thought, this is an amazing program, and this is where I'm going to spend the rest of my career. I didn't know where it was going to go. I was a social worker in a center when I first started. And part of it was our regs, they're very, very team-based. They're multidisciplinary, interdisciplinary, team-based. And that's wonderful because what it does is it addresses the whole person from all the different angles. And we've already got that integrated into our model, which is beautiful. So that hierarchical, where care is dictated to the patient, where in person-centered care it's more of a team-based. Well, and part of the model that I think needs we can support the integration is more participant involvement in the care plan process, in their own process, which is what the person-centered care is. Participant and staff are equal, so it's not like the doctor's dictating what your service will do, but there's an equality, and each of them respect the other's expertise. Participant knowledge of self and choice is integral to improving health, and participant expertise in their own life is paramount in determining the course of care. The person-centered care model, just to go off the side, and you guys may already know this, has been proven to improve outcomes. So this is why it's a great model to even look at from a moral view, from an ethical view, and from a keeping our participants healthy view. And the medical model, it views the participant or the patient in multiple unrelated diseases. So we were talking earlier about the IPC that lists all the diagnoses, and then the care plans that are diagnosis-based as opposed to problem-based. The language can very often be problem-based instead of functional-based. And I can have an example of that. You want to hear an example of that? Sure, right? Okay. So an example of when we talk about the functional versus so an example would be if we make the problem statements in our work in functional language, utilizing participant stated goal would be an example. Mrs. Smith would like to be able to, so this is the goal. Mrs. Smith would like to be able to take a walk in her garden without pain and feel a fear of falling. She's fallen 3 times in the last month and states pain is pretty intense. Versus fall risk related to arthritis and pain in both knees, as evidenced by a participant has had 3 falls in last month and rates pain as 6 out of 10 in both knees. So we're looking at really using, it's such a, it's so human. You're using this functional language. You're using human language. She's not a participant. She is Mrs. Smith. And simply using that type of functional language in our documentation brings it into a whole other level. So we're seeing them as a human, not this bunch of diagnoses from the top to the bottom. So as we're looking at creating this IPC, think of this too as really being, I know there was another word used instead of problem-based, but I go to problem-based instead of diagnosis-based. Need-based. Need-based, yeah, thank you. Yes. So and the participants identified need-based. So the medical will treat the disease and not the person. Person-centered treats the person, not the disease. The human being, you can have 2 participants with the same diagnosis and the same severity of diagnosis, or both have the same diagnosis, and yet one is able to take care of themselves much better than another, and that's based on all the other inputs around them, such as the support systems, their own emotions, their own identified strengths, identified deficits and strengths. And so we're looking at the whole person as we're going forward. The interactions of diagnosis is crucial. So it's not just blood pressure, diabetes, arthritis. It is how is the diabetes, the arthritis, and the blood pressure issues, how are those affecting each other? Also putting in the emotional piece and the cognitive piece as well. How is that, because that again creates this human being, and you're not treating these individual diagnoses. And all diagnoses are important as the participant views them to be and how they affect one another. So I may have cancer, but the diagnosis that's bugging me the most might be that my diabetes is out of control, right? That I'm dizzy all the time, or these effects of the diabetes, I may be saying this well or poorly, but even though one might seem like a much bigger one and it can be aggressively treated, I want to have quality of life. And my quality, there's a lot of person-centered care when we look at the hospice and end of life care, because there's not less concern about this curing and this treatment and this getting better, but more is how healthy is this person feeling? What is their quality of life? So we're looking at this whole human being now. Also, when we look at the medical model, there are clear boundaries between the participant and the expert. Social workers, I remember learning all back in school about making sure we have very professional boundaries between our patients and ourselves. And this now is loosened a little bit. Really, the healing occurs within that relationship. There are still professional boundaries. We're not going to lose those completely. But they're not these stringent of I'm the expert and you're not, or I'm the expert, I'm going to tell you what to do. It's more of this, I need to know who you are so that I can best help you along your journey towards health. And in that understanding is this relationship, and healing occurs within that relationship. The language, I talked a little bit, I mentioned that a little bit here, is very, very often, and again, we're black and white, so it's not to say that we're doing this at all, but the language, medical language, can be judgmental, clinical, and detached and personal, and it builds the boundaries. The problem goals are written in clinical language and are the staff's observation as to what's wrong with you. Okay, I see you, this is wrong with you. I've assessed that this is wrong with you. And receiving, the participants' ideas as to what's wrong with them, what bugs them the most, what gets in the way of them having a great life. And it will, this is when we refer to our patient in our documentation as participant or patient instead of by their name. So that kind of goes into the language. Our language in person-centered care, we want to remove any statement and judgment. It's personal and relationship focused, increases the view of the participant as a human being and not as work. And problem goals are written in functional language of the participant. Another thing that I thought about too that I just wanted to bring up is that we would be, and this might be jumping a little farther than we intend to go today, but in including the participant in our interventions. So the participant right now, the way we've been writing our care plans is it's, and they were specific that we weren't to write. They were all about what the staff would do for the participant in interventions. The participants and the participants' family need to also be included in these interventions. What will they be doing? What will we be supporting them to do? We only get the participants, 12, maybe 30 hours a week? They're home the rest of the time. They're doing something else the rest of the time. So it's part of our job, I think, to empower the participants to help them take care of themselves too. And if we help them identify, as opposed to us telling them, well, you need to fix this, if they tell us we want to fix this, we've got their buy-in with us. So then we can work on the things that are bothering them the most, and that improves their entire well-being, which improves overall health. So that was kind of what I was hoping to kind of get across, so that we were starting as we move forward on this.
Questions or comments for Amanda?
Well, I think that part of what you're bringing up, Amanda, is the reflection over the years of, again, what Lydia was referring to earlier, the directives to write care plans in certain kinds of ways and the oversight. And because telling the story of the participant is something we've always done. We do it in our assessments. We do it. We've done it in our care planning. We've done it in our IPCs. But over the years, there were instructions to remove all such elements.
I
I've got serious introductions on how it was done.
And in part, it came out of it in maybe you guys do TAR authorizations or have, and you speak to this, but we were told during, Phyllis Muchmore and I, when we revised the IPC back in 1999, the medical field officers were saying, oh, for the love of God, we don't have time to read these things. Don't give us Gone with the Wind. We need abbreviations. So we trained to what the medical field officer nurses were telling us to do, to get it down to the succinct. We don't want the narrative. We want the, the basics. And, well, not so much cookie cutter, but just the abbreviations. Yeah, more, less narrative, more.
Just get to the problem of the intervention. And
That's right, just get to the facts. And so,
And we've always included a summary on our IPCs, regardless of when it was eliminated. Sorry. But one of the things that we did see was, when things going to those reviewers who shall remain unnamed who are at the field office, but that if we would emphasize strengths, as we were wont to do, because our program is designed to build on the strengths of the individual, that they might not understand why the person had the need for the program. So in elucidating the need for the program, all those risk factors, that's why, and I've had my nurse say, but this participant, is a person and has all of these abilities, and, I don't want to make them sound so disabled, yeah. And so I think that being able to get at why they need CBAS and still identify, all the things that Amanda's talking about, the strengths, their person-centered, they're just their interests. But the reasons that they came to us and they want to be there, it's a voluntary program. That's kind of where we're trying to aim for. That's what I'm thinking that you're getting at, is that, let's aim in the direction of being able to identify all of these things as aspects of the person's care in CBAS without fear even of having the person then eliminated because they look like they're too competent.
Right. And let's hope we've evolved somewhat past that now with the health plan having the role of doing the face-to-face and or determining eligibility through some other means.
Yeah, we're not finding any difficulty with that.
We're not arguing about whether they're eligible at that point. Now we're talking about who is this person?
Yeah,
I can understand why it's so frustrating. I don't know what the other managed care plans, how they view it, but when we view it, in the beginning, oftentimes there wasn't enough information in the IPC for us.
There you go.
And if we bring cases to rounds, maybe in the medical, and the physician reviews it, he wants to know all of those details.
Yeah.
They want to know the stuff that you guys are putting in the summary, because I guess from a managed care plan, we're in a way responsible for that member's overall functioning or overall care. And so sometimes when you see, when we'll see an IPC, that most of them all include this, but I can say something that we saw maybe when we first started getting IPCs was that, wow, this person doesn't have any caregiver at home, they're completely disabled, it sounds like. What do they do when they're not at the center? And is someone taking care of them or not? Because if they're not, then we as the board need to get involved and do something.
And I think that this is what I wanted to bring it up too, is because I think we've got, we're on a continuum. So there's centers like Diane's, which are like chomping at the bit to want to do it in a person-centered way, and are doing it in a person-centered way too. I'm not saying you're not. But that we've had these instructions and we've had this fear, of if we don't do it this way, this poor participant is not going to get services. So we've kind of been conditioned for our participants' survival to do it a certain way. But I think now if we can kind of remove ourselves from that position and kind of go forward knowing that, we can write a strength-based care plan. We can use the participants' involvement, and when I say participant, I mean participant and their family, whoever else they identify, not like just saying the participant. It's just a lot easier than saying all the words. So, that's good.
No, I'm agreeing.
I want to be the voice of reason here, because I don't want to create a document that's going to capture all these wonderful things that also is as time intensive as what we currently have. So I like strength-based as a term of what we develop, but I also think that the chart is, and the team role and everything that we do at the center, which is documented to the hour practically, is a reflection of the amazing care that we provide. So I just want to be careful because I hear your point. I mean, I can imagine you pull an IPC and you read it, you know nothing about this person other than what medications they take, and do they have IHSS, do they not? I mean, it's quite stark. And we don't do the narrative anymore. And the reason
still
we
a
do
lot of
and we stopped is like, who's really clear?
Yeah.
We know that. We understand that as an IPC. And we work with that and we grow with that and help. That is our foundation. Do I need to capture that on the narrative on page box 27? That's a lot. That's a huge time consumer for social worker directors to fill that up. To update that and make sure it's really reflective. So anyway, that's just my point.
It's finding that balance.
Yeah, we have to find that balance. Yeah.
Yeah.
So we also have a follow-up comment from Bob for the same topic. PCP may start an assessment with abilities, not just the diagnosis.
Super dry, itchy,
Ability,
red lines in it.
assessment and treatment system. They make a person feel vital despite their disability.
So,
Or it's kind of long. Is there room in the IPC for this when you get paid for identifying deficits? People should not feel put off to pasture in CBAS, but find creative ways to system to feel vital.
can't, unless you're
Thank you, Thank you, Bob, and I don't think that we have answers
He's
to
on
the
the
question.
computer,
These are all
so he can't speak.
like that, like
But as we go forward and
Well, I think we've gotten
all over
change has been just to address what you're talking about, and that is how do we find better ways to engage the individual in the care of their own needs? How do we improve what you call health literacy? How do we engage in a lot of the person-centered approaches during our conferences to help that the individual even identify what their strengths are. They may have been told so many times, you can't, you're sick, you're sick, you're sick, that they've lost confidence in their own ability to manage their health and their well-being. So I think it's this whole mind shift that's happening all the way from the Affordable Care Act trickling down to all of us here. I see physicians struggling with this, as well as health plans need to. So I think we're at a point in our time where we're all kind of struggling with the same thing together, which is a real opportunity, right, for all of us. And I've sat in on rounds that Anthem does on beneficiaries, and they are drilling down to, and isn't it refreshing to have health plans who care about their member as a person and not just, well, let's see if they qualify, check, you know what I mean? So I think this is a real opportunity, and I'm very mindful of your comment on you've got to strike a balance. We need to know what you guys want and don't want too. You also have the face-to-face. You've got data from the CDET. If that's going to stay, are we even looking at that?
Well, I know we're starting to hear from plans that they wanting to know what the rules are around waiving the face-to-face. So we have some plans that are interested in doing that. So in some cases we'll have the face-to-face, in some cases we won't. So we'll look at that going forward.
So yeah, it's.
But I think the important piece of that is that, and I think it goes to some of what Amanda said, is that we need to stop arguing about medical necessity. You started about medical necessity in the IPC. That argument is settled by the time we're writing the IPC. So we shouldn't be in a fear-based position when we're writing the IPCs. It should be all about characterizing the participant as best we can for and careful.
Because we come from this idea that we're the provider of last resort. That everything else has been, everything else has been examined, and despite all that's out there, this needs can't be met. Okay. And you can
it's a new era.
CBAS.
So that one.
Well, relative to the possibility that the face-to-face might not happen, and the person comes to us, what I want to really be clear on is medical necessity has been settled. How is medical necessity getting settled?
I think that we still need to make sure that that person meets criteria, right? And that happens during the face-to-face. But if we had, let's say, since our as the plan, the nurses are, our UM nurses are doing the medical review for someone who's inpatient. Well, we have a ton of functional data about that person and information about what's going on with them and their level of functioning. And so since we're the plan, but we have all that information, it might be a lot quicker to get that person into CBAS if we don't do the face-to-face. We already have enough information on them based on what we have to fill out the CNET.
Yeah. Were we having this conversation recently? I'm having it.
Oh, I think, yeah.
And I know I've had it with a few plans recently, but yeah, so then if the plan is choosing to say, for these kinds of participants, we're not going to do the face-to-face, then are they going to fill out the CDET? That's their policy at that point. Or how else are they going to demonstrate medical necessity? Because medical necessity isn't settled in that sense, Diane, because the plan is still going to get evaluated by audits and investigations and everybody else about whether people meet medical necessity. But it's going to be on them to make sure that they've got documentation and this is how this person meets it. Now, what I was saying is that we shouldn't be arguing about medical necessity when we get to the IPC, right? Because we have that plan in between.
Right, but I'm kind of saying that even my question came up, regardless of what you were saying, because it's been one of the core questions in my mind related to revising the IPC, because that box does have to get checked at some point. You guys have to check it, we have to check it for you, and then you can confirm it or however. But we have to be sure it stays in the process as we go forward. And it led me to thinking back to the idea of the summary, for instance. We don't do an equal summary on everybody. Sometimes we don't do a summary at all. So really the summary statement it has been in order to help to fill in the gaps, where they need to have more information. And what's usually done is an initial statement, things like my participant I presented some time back who had multiple hospitalizations for many years, psych hospitalizations prior to coming to our center, and then never had another psych hospitalization. But we left her history in that box 27 because otherwise she became so stable that you could not see why she had still had needed the program. Right. So you had to have the history. So what I'm thinking is maybe we could back into some of this stuff to Dawn's point and keep it streamlined as possible. That where things like that, where they're needed in order to continue to see the need of the individual, or where they're needed by the plan in order to see what other services they might need.
No, that makes sense because we know they qualify for CBAS, but when we do our reviews, a lot of the times we're looking to see how many days a week meet that member's
That's what I was going to say.
meet their needs.
Yeah. Part of so if we get looked at the IPC, but what the IPC is built from is our assessment process. And so, and Bob even mentioned on the phone that we're doing it in centers. A lot of centers are doing a deficit assessment process. Boys say that 10 times faster. Where I think the assessment process actually, as we move towards this, will become a different type of assessment too, where we're looking at the whole person. We're not just sitting down with with some of the centers, it's a continuum. Some of the centers may just check off their stuff every 6 months and make their assessment as quick and fast as possible. The thing is that we know whether you write it, whether you write a narrative or not, we know our participants. So if you have a participant in your center and you have an IPC, it may not match them. You ask any of your staff, tell me about this person. We know a lot about them. So it's a matter of how to get that information that as we build a relationship with our participants. If they've been there for a long time, the relationship is already built in. So we know our participants. So that's kind of where the summary is built from. And we should have a summary, or maybe not on the IPC, but there should be a life history. This goes to the biopsychosocial spiritual assessment that we might want to take a look at some point too, and the integration of the biopsychosocial spiritual parts of the human being, and then build that into that and motivational interviewing and all that. But there's lots of pieces of our assessment as we go forward that is going to change too.
It's hard to talk about IPC without talking about assessment. That's okay.
And this is making me think about, I'm making a comment about when you look at a person and who are they. And one thing that we're learning as we go is how our health plan can be our partner. And I would like to see the IPC allow us to say what we're not able, what need this person, what goal this person has that we're not able to meet. And let's create a dialogue now with the plan so that we can optimize resources, because quite often there are things out there that the plan could assist with, because there's a lot of flexibility these days, amazing flexibility.
Which goes right into that conversation we were having before about the, the case management piece. So that if, I mean, that bridges that number 2 completely.
Yeah. So I'd like to be able to alert the plan. We need some help with this, right? Yeah. Let's take this to your team meeting and maybe we can come and participate in that, or maybe there's a way.
Or maybe that person needs a case manager.
Yeah.
And you guys can work with that case manager.
Yeah. Because I think sometimes we try and look like this is it. You got us now. We're going to take care of everything. And we're not that good. Yeah, we're not superheroes, but we try very hard, and we love partners. We partner very, very well.
Right. Okay, any more comments based on some of the opening remarks?
Great.
Okay, well, obviously Amanda got us thinking about a lot of things. Lydia, do you want to get us thinking about things before we do the anatomy of the IPC?
No, I mean, I think we've covered it. I wanted to share, a little bit of the thinking from our work group that I did earlier with the quality, the quality conversation, and how we could start to measure some of these things. And I think all my point was there is, it seems when you first look at something like, oh my God, how are we going to measure this? It's process, or it's so kind of global. But if we think about it enough, I think we can come up with some good measurements. So that's where this group will feed back into the quality and measurement group, kind of that direction. And I think, Lydia, one of the articles, I can't remember, but one of these 3 articles actually touched on measurements of person-centered care. And it might have been this. Yeah, we've got a ton of.
I'll look at it.
Yeah, we'll look too.
Yeah, anything that you guys have that you think that should be shared with the rest of the groups, let us know. We'll put them up on the website for sure. Okay.
So did you want to? I'll give my proxy to Dawn or Don in a few minutes and comment.
Senator from
to say for kind of overview comments around the IPC changes. I'll give my
Well, I
time
think
to
we
you
just
guys.
captured a lot in that last 5 minutes relative to using it as a communication tool, to be able to look for ensuring that there is a comprehensive attention to the person's full week, not just the time they're spending with us, but without taking the burden on, and I don't mean burden, but actually it's more like if you're really going to look at how independent a person is, and then you have to start from that point. So just like I was saying, not everybody needs a service plan. Not everybody's going to need additional care manager and so on and so forth. But when they do, it's really important that we're working together and that we're able to communicate what that need is. And when they need more days at the center, for instance, that's really important that we're able to communicate back quickly when they just had a hospitalization or something. So I think really looking at from that perspective that it's a flexible, there's a flexible process in which we can really identify the right level of attention and services for this person in our centers and communicate effectively back and forth around that. That was standing out of that last conversation.
Yeah, I think the other piece that ties back to the quality and the literature and what, the outcomes pieces, there are certain things in the IPC right now that are really good and we want to retain around. For example, we know medications is a risk factor. Number of meds, higher risk factor for mistakes and so on. The ADL and IDL chart, good. We've actually in TOPS, we turned it into behavioral anchors.
Right.
So each of these has a sentence now. So if you're going to interview someone, discuss someone to get a sense of their ADL and IDL functioning, you could ask them the questions or their caregiver the questions. So I think, we talked about that being good. There's other pieces of information in here that is helpful to paint the picture. The plans find it of value. So it'd be interesting to hear from Selena and Amanda sort of what
you find useful and what would be like, we skim over that. So there's, it may not be as huge of a undertaking, like you said earlier, Denise, as maybe we think. And then just to Amanda's point about language, the other thing we had talked about last week was language in the actual IPC Box 21, changing, using the philosophy of person-centered, and as simple as changing from problem to need. And then, we should be talking later about what kind of measurements do we want here? And how does this relate to frequency? And so maybe there's some more current thinking around that. So that, you guys will have to help figure out. And the only last thing I just wanted to say was, the literature right now talks about function. So that's the big focus. And for our population, it's the rehab model, right? The rehab philosophy and function is it. So this is all good stuff. So do you guys have any feedback from your teams or your experience, Selena and Amanda, about kind of what you kind of go, when you guys look at the IPC?
From HealthNet, I believe Linda Jeffrey, is she on the?
She had trouble getting on this morning when I sent the email. She had said, I can't get on, try again,
no.
So I don't know if she's on.
She's a manager of our team that receives the IPCs and reviews those, so I would defer to her, but if not today, then for the next, work group as a follow-up session, we can.
Linda Jeffrey,
okay.
Yeah,
And she's listed on here.
CBAS, okay.
Because she tried.
My thought on the IPC, and this goes to the efficiency and the effectiveness and decreasing the amount of documentation to increase the amount of time to spend with our participants, is that we look at the IPC and we erase it, completely erase it. What's required by the federal government under our waiver, and then what do you guys need to have on the IPC? What do the managed care companies need? That's the IPC. My concern always is that any information, and maybe we don't have to worry about this as much anymore, but the duplication of information. So if we're already assessing the ADLs of a participant in our assessment process, why, unless you need it, why transfer that to the IPC as a separate question? Unless there's reasons for outcome measures that we want to use. So, again, to decrease the duplication of information and to decrease the overwhelming amounts of paperwork that you guys might receive. What exactly is it that you need? And then and then on the actual care planning piece, how do we design this care plan? I've had some discussions with Denise about it, and I've thrown it out throughout the years, is that, that the whole, is this the time to bring that up?
I don't know, go ahead, you're already bringing it up.
That the whole IPC and the way that it's designed, that we stop using it that way, and we make it a needs problem-based IPC as opposed to a discipline-based IPC, where we start with, instead of starting with the discipline, which pulls everything apart again, as we're addressing, instead of being person-centered and holistic, we're addressing the actual diagnosis or pieces by pieces. The nurse is going to do this, the social worker is going to do this, OT's going to do this. We actually start with, this is the problem, that's the first part. These are the interventions. The nurse will, to address this problem, the nurse will do this, the social worker will do this. It's kind of goes back to the skilled nursing facility IPC that they use, which is an IPC that they use. So all the disciplines that would be involved, and then this is the goal. So all the disciplines, we've got the whole team working at it again too. So we've got the team and the interventions together working towards the same goal that the participant has identified, and potentially even the participant is involved in these interventions. And so that we can measure these goals better too, because there wouldn't be like 18 different goals and Gone with the Wind. It would be one goal. Did they meet the goal? And it would be part of the goal would be the participants. So where I always said, you can't have mushy numbers. When we go back to how I was teaching all the clinical, care planning stuff, you can have mushy numbers. But if a participant says, my pain is pretty intense, and you ask them 6 months later, it's not a 7 out of 12. It's not a clear clinical number. But if you ask them, 6 months later, how's your pain? It's not so bad. That is, it may not be as clean and measurable as a number, but you can still see that there is, and it's more human. So that would be my big monster.
That's an interesting way of designing an IPC. It does reduce duplication because you'll have social work and nursing and therapy all listing the same challenge or problem. So I like that.
So let's talk about that when we get into the boxes. I think it's a good idea. I think Amanda kind of, she and I have had a lot of these conversations over there. She's more of a sort of zero-based budgeting kind of a gal. You know, so let's start with zero and let's add on to the IPC what we need to do, as opposed to like what Lydia was maybe proposing, maybe Dawn is let's do the minimal amount of changes necessary to, you know, to get the job done, so we don't have as much.
Well, yeah, figure out what's working now
Yeah.
and what isn't. And then you have to be attentive to the measurement part because that is what drives reimbursement,
Yeah.
it's what drives QI, it's what
Right.
drives everything.
Yeah, and the other way of achieving what Amanda's talking about too is that we have the more those more hard numbers that we have in the clinical world, the 7 out of 10 pain scale, but then we also have the participant statements about it in some other tool that captures in their own words what it is that's going on. So there's different ways to get to the same objective. And we're going to say something, Dawn?
Well, I mean, I guess one thing I was thinking about is I want to be cognizant of creating something that can't get us in trouble again. And when we talk about
We're in trouble too.
Yeah.
We get a lot of it too.
And you know, we do have a spectrum of providers. We have, you know, very quality-oriented providers and very minimum, whatever we got to do for the minimum. Yeah, so we got to make sure that we build an IPC that is foolproof, because if the face-to-face doesn't happen because the determination was, and then we find this person and we actually provide services, and within 12 months we're making it. I mean, it could happen for us. You make a determination, no, they're not really meeting eligibility.
Right.
We have really
We
been
graduated.
successful. This person has really been motivated. Boom, you know what? They're not meeting criteria.
Yeah.
Let's start talking about discharge. Now that's not every center would go there, right? So now we've got a person that's potentially not meeting criteria, but the plans have trusted us to continue to monitor that.
Yeah.
So those sort of things.
Yeah.
How can we
Yeah.
make sure?
Yeah.
Well,
So let's keep that in mind as we go forward too.
yeah, and I'll try to keep this short, but as an addition, I do like the thought of being open to blowing it all up. But the clinical aspect I don't want to lose. And the reason is it's not medical, it's comprehensive, it's holistic. And it is important to be able to distinguish between you know, the participants' desire, let's say, to be with people. So, and the fact that they are, you know, highly at risk because of their out of control blood sugars, blood pressure, you know, all of the things that the nurses are going to be addressing. And yet social work has a different focus that they can follow while nursing works with them to, you know, on their understanding of their diabetes, on their desire to be able to eat in a certain way, and they find a happy medium to help them go forward and live. You know, I don't want to lose all of that clinical stuff.
and
so I know you don't either. So that's why I'm trying to keep this short and sweet. So if we keep that in mind, though, I think we could come to some maybe fresh perspective. Because ultimately, I don't even know if everything has to be submitted to the plans. If we have things that we hold back at the center that guide our care, and that's very clear. And we're auditable. We can provide them if needed, et cetera. And now we've got maybe the best of both worlds.
I'm glad you said that. That was definitely a piece of this. You know, our thinking before this is that thinking about the person-centered plan and the IPC is sort of this modular thing that it includes, you know, the participants piece of it and their consent and their agreement and stuff about the process, and then it includes the demographic information about them and various other services they're getting, and then it includes the care plan itself and which parts do the plans want. If you want to just break it down. So let's think about that as we go through too. So let's start walking through the IPC. A word before we do this, I just wanted to mention to you that at least the way I'm envisioning this process is that whatever we come up, well, first of all, we're going to be putting things up on the website for everybody to see. So anybody can give us feedback at any old time, and we'll bring that back to the group. So if we get comments from the plans or comments from our other CBAS providers about what we're talking about in here, we'll share that with all of you. And then ultimately, whatever recommendations we go forward with, because we want everybody to join arms together on this, whatever we come out of this group with, we will share it with DHCS, with all the managed care plans, with all the providers, and invite their input so that we make sure that we don't do anything that doesn't have everybody else's buy-in. So how we'll make that happen, I don't know, but we will put that out there for everybody to make sure we're
They
inclusive.
need to speak up as we go.
Yes,
along.
they absolutely
You see
do.
as you move.
Yeah, they absolutely do. But just wanted to make sure you guys knew that about the process, so we'll get everybody else's feedback. So let's walk through the IPC and just talk about what's here. And if anybody has any like insights about how something got in here, because I think this has this might be worth sort of help us with some insights about this.
It happened in this very room.
It's very possible. So let's share as we go through this. So starting at the top of the document, we have the board. Oh yeah, we have hard copies and then copies on the board.
Hard copies? I don't have hard copies.
Oh, you don't have any hard copies?
It's up there,
Okay.
so we can carry it over, we can follow along there.
Okay, so we have header information, and some of the stuff artifact-wise, I do not know, and we'll count on the plans to tell us even basic information like in the header, whether car control number are still important in the header numbers. I don't know if that's relevant to every single plan. Okay. For every single plan is what I was getting at.
Yeah.
Okay, so we've got the header information, we got the dates of service. And again, just as we go through this, everybody keep in mind, we have health plans now that are authorizing 12-month plans.
Yeah.
Okay, so yeah, we do, big ones. And so when we talk about a 12-month TAR, the thing that we have to keep in mind, through our lens at the statewide program level, the same regs and same laws still apply, so everybody has to do reassessments and assessments on the same schedules and IPCs on the same schedules. Whether the plans authorize, and that's their discretion, every 12 months is up to them. Whether they want to ask for a updated IPC at month 6, that's up to them. Or whether they just want to say 12 months, got to be with you, that's up to them. So we have to remember that the MCPs, the plans own the authorization fees, but our statewide program requirements still apply. So dates of service, that's my way of saying I think that still applies, for a 6-month period.
Correct.
Okay, so check boxes up top, whether it's an initial, a re-auth, or a change TAR, those should all probably be the same. Planned days per week, that's what the center is asking for. TD clearance, I don't know if that's important to the managed care plans anymore, but that was one of those things that I think back in the day we thought we needed to insert here just to verify that we had TD clearance done prior to enrollment. It's a one-time thing in the regulations for this program. You only have to do it prior to their first enrollment. So I think that was one of those sort of attestation kind of things that we inserted during the A&I.
I think that's kind of a licensing thing.
Yeah, but again, does it belong in the IPC?
No.
I don't know.
Are we deciding now or just going?
No, I'm just sort of throwing these up. We're gonna have these all on the inventory on the so. And then signature H&P. So we're basically, this is actually an artifact I think from 1755 that we're saying never developed the standard H&P and agreed to that. So we're just saying yeah you have it. So again, that's kind of an attestation kind of piece. All right, that's box 1. Box 2, we have all the diagnoses and the ICD codes.
Oh, wait. Oh, okay. Hang on.
Right?
I just wanted to, go ahead.
I don't know if primary and secondary still is as germane as it used to be. I think that to a large extent we're getting away from primary and secondary, aren't we? It's just kind of all the diagnoses.
No,
not at all? Okay.
We use primary and secondary.
Okay.
But we might want to change the terminology there, you guys, based on what you said earlier about the emergent condition or the most relevant condition, or
We have to use your primary diagnostic code to submit our claims.
So managed care needs them.
yes.
Yeah, okay.
To submit our claims to managed care. And then the thing about the secondary diagnoses and all of that, well, if we wanted a document that would describe why the needs the program, then putting the full diagnostic list helps a great deal, because it does make that the medication list. You can look at that coupled with the ADLs and IDLs, and you can see pretty clearly, a level of risk.
Yes.
Right up front.
And I think diagnosis is one of the federal one of our.
Yeah, it's one of the
You have to have
requirements,
it on there.
it's in the regs, yeah. So there's some things that we're kind of locked.
I would
into.
add, yeah, anyway, for.
Now, what's interesting though about this is it says confirmed by the PCP. So I raised that as a question because now with the new ICD-10 codes, there are all these social determinant of health codes as well that are, I think, new. I don't use ICDs, but there might be opportunities with the new code system to identify, again, for the purposes we talked about earlier in the quality work group and data and QI, to identify some related social determinants of health type of codes that would flesh out the picture of that person. What I don't know is it legally required that diagnoses have to be, does it say confirmed, provided or confirmed by the PCP? Is that a legal requirement that diagnoses can only be made by the PCP?
Well, the PCP needs to diagnose, we can't diagnose.
It has to come from somewhere.
But it comes from the PCP.
Okay,
Or
so I totally get what you're going on this. So let's say we remove that statement because an LCSW or a psychologist can make a diagnosis. So it can
qualified.
So it can, so we, you know, it doesn't have, it's confirmed by the PCC. A lot of times, you know, do we need to have that?
I don't think we necessarily need to say personal health. Well, personal health care provider, I would actually see as including somebody who's providing the mental health services for that individual.
So operating within their.
I wouldn't think of it
Yeah,
as just a
okay.
physician.
I think that's why that was
Anyone
just.
operating within their, yeah.
That was until I'm going to change that to include nurse practitioners as well.
Do we need, so do we need that? Do we need to have, I mean, do we need to have include the diagnosis as provided or confirmed? Or does that leave us
sounds
open
like-
for
yeah.
some, does match care?
No, it says if you don't have documentation that tells you that someone has diagnosed that individual in that way, it doesn't get included there. So we might guess somebody is depressed, and so it says, oh, they seem depressed, so we would write that down there if we're not a knowledgeable provider.
You would
But-
write it if you weren't, sorry, so it, okay, go ahead, I'm so sorry.
What I'm saying is that what this statement is trying to say is you don't include it because the center saw it and thought, that must be true for this person. You only include it if you have backup documentation that shows this is a diagnosis made by someone within their scope of practice.
So let's do this for today.
Yeah, make some notes.
Let's flag them, let's flag these issues and we'll do whatever research to, you know, to bring back about these. I think it's worth discussing. But can somebody give me let's say the issue of social determinants of health one? So
ICD-10 codes have some new things that drill down into, I mean, I'm going just from memory scanning some things like living alone. It's got some non-clinical risk factors, let's call them, that might be of interest to all of us collectively. But I don't know if doctors are going to drill down that far. I don't know.
And we don't know who's qualified to identify those.
I'm just, I made note as I was doing our thinking about ICD-10 conversion, I was kind of researching. I went, oh, there's a whole bunch of codes here that are our people.
Yeah, and if we were able to identify them and use them, it would be a way of communicating quickly and also track.
Exactly.
Yeah,
It
right.
has to come from somebody who's qualified to give a diagnosis.
And I guess my only thought on this is that, is it something that's going to catch us at some point? This is something that A and I caught a lot of people on, was that, you know,
that's a lot of where that came from, is that it was confirmed. It wasn't that, like, we had some sense that somebody was depressed. It was actual clinical diagnosis.
And we're all saying that that's, sounds like that's,
we want that.
the plans want that. Yeah.
And any observation we make, we can share that with the physicians, we state the case, and the physician will also not agree.
Okay, moving on.
But on that note, no, back to primary and secondary.
Yeah.
Who's making that determination? And so I think we want primary, and we get that, but is everything, do we need to use that word secondary? Could we just say other? There's the primary, and then there's the other
diagnoses.
Right, so that we're not strategizing or tiering.
Stratifying.
Yeah, stratifying.
Yeah.
Okay. All right, I wrote it down.
Research, not being the clinician, I wouldn't want to say, because that may be a term that we,
Okay.
I don't know.
So Deb is our lead nurse, and she's a working lead, so she does the assessments and does authorizations as well. And she's saying that when we, at least as the plan, look at the primary diagnosis, we're assuming that that means that's the primary reason, that's the diagnosis that's driving the need for CBAS.
Okay.
Kind of like we were saying, if someone has dementia, they also have diabetes and hypertension, but it's really the dementia.
And actually, we're not looking at it that way. So the reason we're not looking at it that way is because we can't diagnose. So we go to the physician and say,
Right.
what's the primary diagnosis? Their need for CBAS may come from their secondary diagnosis. So their primary diagnosis might be
Is whatever the
something
PCP
cardiac
says
related.
is the primary diagnosis.
Yeah, exactly.
Okay. And that actually, just to jump ahead, something that Amanda mentioned earlier that we've had conversations about, that if we were to rethink the construction of the care plan boxes and to think about it in terms of what are the primary presenting problems that brings this person here? What is the primary need for CBAS that you're going to address? And we had the disciplines all intervene based on, you know, what those primary drivers of their attendance are. That it's kind of a rethinking of things, and it gets at what it wants for authorizing. Why are they here? Maybe it doesn't have anything to do with their primary diagnosis. It has something to do with the functionality, you know.
They fall all the time.
Right. So it's just another way of maybe getting at what that need is.
Yeah, I accompanied a very old person to a doctor's appointment recently, and the doctor, I've never heard this, I think I shared it with Diane because we talk all the time, and he said, so what troubles bring you here today? And I had never heard that before. The rest of it wasn't very person-centered, but I thought that question.
Yeah, he went to a class.
But
If he had been working with Amanda, he would have said, what strengths frustrate you?
I mean, he didn't lead with, you know, anyway, but it was like he was using colloquial language. He was somewhat open-ended, you know, to get an open-ended response. What trouble?
The scissors.
Daisy had a question actually before we move on.
Great, Daisy's back on the list.
If MD does not specify that a participant lives alone and would find it during the assessment process, can we include an ICD-10 code as additional information?
I think maybe that's one of those questions, that's what Lydia's saying about the social determinants. We don't know the answer, but we're going to look into it.
I don't know much about this.
Yeah.
Not about this.
Maybe it's I don't know. If the social, if the ICD-10 codes, I'm just thinking if the social determinants are there and they impact, maybe those, you know, maybe those get included on the IPC. Just a list of, you know, and why it's not. I mean, for me to write an ICD-9 code,
It's a shorthand.
it may not be a diagnosis. Sorry, thank you. I mean, for me to write an ICD-10 code, you know, do I have to be a doctor to write that, or that's what we're trying to find out.
That's what we're trying to find out.
But, you know, I just realized it doesn't really matter on the social determinant. So, I mean, as far as whether we assign a code or not, that might matter.
Right.
But we can still.
You can say it.
I'm not trying to. I'm always trying to connect back.
No, I agree, and I think we should if we can, but let's get them in there anyway.
Yeah.
Focus down the road.
Okay, moving on. Okay. We have medications. Frequency and dose are not required. That's in the margin there. So is frequency or dose something that would be relevant? I don't know. We can throw it in as a discussion. No, Diane says no.
No, we talked that one out.
Okay, we talked that one out. Active prescriptions, just noting that it's not there. Active prescriptions, and then we have over-the-counter medications or supplements. Okay, so just that.
Is this a federal?
Thinking about. No, medications is on our regs. Well, so they are. They're both now because they're in our Title 22 regulations and they're also now in the
To be in the IPC.
In the
But they
IPC.
have to.
Yeah, I'm pretty sure. Look at your.
They all have the
Yeah, it does.
It
It does say it has to have the list of minutes. Not all the time.
No, they won't.
Okay, so I'm looking at.
Yeah,
Yeah, prescribed medications is on the list.
You'd have to cross-look somewhere.
They don't.
Oh, yes, probably
But
in
I'd
the
like
list.
to hear the rationale, not today, but the rationale that you came up with, the frequency and dosage. We don't need to talk about it now.
Yeah, not today.
I'd like to hear.
Let's try to get through the overview.
Yeah.
We'll drill down in all of
It had
these
to do
boxes.
with timing,
Okay,
how frequently they change.
all right. So we move through the box 4. We're only on page 1. Okay, box 4. This is the personal health care provider. So who's the physician, address and phone number. Again, I think this goes back to, again, to A&IO, just for refreshing everybody's memory, when A&I was coming in, and concerned that we had people in there that weren't getting authorized by the personal care physicians, et cetera. They was like, let's put the personal physician's name right here on the front.
This who you said?
Whether we need that going forward is another discussion.
Yes.
Scrolling down, now here we are in the box of criteria. So I guess the one thing that I would share about all of this, the criteria boxes are 5, 6, 7, 8, and 9. And so they take up almost total a little bit over 2 pages. And so what I would say about these, I think that when we were doing the transition from the old IPC where we had the old criteria that were significantly shorter to these new criteria, it was really challenging to do this in order because they are so detailed. And I will tell you, I talk to people all the time, health plans and providers who do not know how to fill out these boxes.
Yeah.
They're so
Not
confusing.
yeah.
So, and I've gotten to the point now where it's like, I don't even want to talk to them. I just say, they're all messed up. You guys decide what you want to do.
We got a work group started.
Yeah. So whatever it is we try to keep, if we do around eligibility criteria in the IPC, some of you using at least some kind of a validation of what category the provider believes they fit into and how they meet the criteria might belong there. But we cannot keep this level of detail. I think it's just impossible.
Yeah, Kay just said it. She said, gone, gone, gone.
Okay, go on.
Thank you, Kay.
No, the only
Okay, so
place
we're
we
very
end
key
up
on what
with
we're-
some
Summary statement about category we believe they qualify.
Right.
Yeah.
And you know, we still want to maybe keep it as a little reference guide, especially for the new providers coming in.
Absolutely.
But it's not part of this, it's just a run.
Part of the IPC. Do you remember this grading tool we developed way back?
Yeah.
Very simple.
We still use I do.
Yeah.
We do. Let's bring that out, Dawn.
Yeah. Well, and again, that's when we talk about our work tool for this work group, maybe that's something when we talk about deleting that box that we say, let's resurrect this as a best practice tool for centers.
Yeah.
We also have some really good guidance on our website around requirements, and I direct the managed care plan people to it all the time because it's like it has everything in it. It has all the citations, and it has how each of those different ADLs affect, category number 2 and category number 4 and all that stuff. So there are good work tools out there, but it doesn't belong in the IPC.
Can I make a little comment on that? It has happened that the nurses that come from the plants, they're very busy, and they're running all over miles and miles. They have determined someone eligible, and then we do the assessment, and we say they don't know. So I think it's important to acknowledge that the job is huge, the depth of detail is very shallow, and when you dive down and really get the picture, they may not meet eligibility criteria.
So part of the assessment process would certainly be this tool the tool that you're talking about.
Yeah.
As part of an assessment process, and maybe that gets integrated into the assessment process every 6 months. I don't want to add any. I'm not
right.
That
there's some, because again, I don't want us to get back in trouble.
And my thought on that is, I don't even think. I think if we're going to add a summary of eligibility, maybe it just gets tucked into the summary box, and make it. Because again, I'm always going to go for the little, when I say why, I'm not being, I don't know the right word, mean or questioning, but just I'm always, that we have good reasons for keeping information.
Yeah.
Or, just giving us whys behind, So a summary is, we could put a summary of the eligibility into the summary box if we feel that's necessary.
And if you don't feel it's necessary, I think still having the centers feeling like
as an assessment,
they have a best practice screening tool that they can keep in the chart that says this is how we identify it. Yeah.
Right.
And you have your fingers on that tool?
It's on our website.
Is it?
Yeah. Oh. I'm pretty sure it's what we used for the transition for all of these.
Yeah.
Okay, box 10. Box 10 for the participants diagnosed with chronic mental illness. This is a piece that I will tell you continues to perplex us and our mental health geriatric consultant, Lynn Benjamin. What do we do with this box? This box came of age, I think, back in the 2000 revision of the IPC, when we were seeing some crossover of individuals that were to get county mental health services that were being served in ADHD, and we had a big educational campaign around with our Medi-Cal nurses to tell them that these are not mutually exclusive benefits. And so it's okay, but we wanted to have something in the IPC that identified the center's efforts to do liaison as required by regulation and to ensure that beneficiaries who were receiving CBAS and had mental health diagnoses and met the included diagnosis criteria, that they were also informed about their right to receive services in the county. So this was a sort of a collaborative effort between the Medi-Cal program and us to put in there in the documentation a trail for mental health participants. Yes.
So I have a story about this that I was just told last week at PCC training from one of our participants in Inland Empire. And I don't have an opinion about this box, but I'll just share this quick story, which was that he has a behavioral health focus center. They have a number of participants. This participant has been with them like 10 years. Now, somehow, I don't know why this has suddenly emerged, he also has county mental health services, and the county mental health case manager is telling the center that this person can no longer go to CBAS because it's a duplication. So it's the same issue we confronted there. So with the plan's new responsibilities for behavioral health, which is not the same as what county mental health provides, I don't know, so I don't have an opinion, like I said, but I wonder if this isn't a bit of a conversation we should have at the next meeting or two to make sure we're identifying people correctly who may need maybe your support versus county mental health versus, so I don't know if it's this kind of a box, but I just share that story because that has raised its head again in the Inland Empire, and the managed care plan is kind of being hands-off about it right now.
And yeah, it's interesting because if the participant, so whoever their psych consult, because we provide psych services in the center, you know, as part of the consultants, provide psychological services. The psych consultant, the psychologist, the LSSW should have contacted the county mental health person. They should have. I mean, it's part of our assessment process is that we ask the participants, are you seeing someone? And
that's part of what this box is demonstrating.
Right. And I see this as kind of anyway. But I'm saying.
I don't know any of the details of why they're not, why all of a sudden this has become an issue, but I just share it because it seems like there's still some confusion about roles and responsibilities.
There is, and I'm here to say I have.
And I think the plans are having the same.
Yeah, but I don't know that we would see it as a duplication.
Rather have chicken tacos?
So much more.
Well, and it wasn't the managed care plan saying this.
It's
Remember,
the county.
it was the
County
county was saying it.
Right.
Not the plans.
No, for mental health.
They do. For severe mental health, they're county responsibility.
They're not doing anything.
No, not for CBAS, they're providing other services.
Yeah.
But
Medication compliance.
The refrigerator day.
What do they think is a duplication? The fact that there's some psychosocial support offered at the CBAS Center?
Or the psychological counseling.
I think if they show the mental health.
We had the same conversation with the field offices a decade ago, so it isn't a new idea that there could be duplication, and maybe the county is under a lot of auditing pressure right now. Who knows what's driving that?
Well,
Suddenly it's become an issue. Could be federal auditors are coming in and they're getting nervous. I don't know.
Well, this was raised by CMS when they were talking about the waiver.
It was raised by CMS during the
Yeah, it's a sensitive area.
It was also
because-
raised during our behavioral health plenary session last year at CADS, where we had LA County there, and we had our LA County rep talking to us and saying, we need to talk more about how this works. And
It's a tricky area still, you guys. That's all I'm saying. And I don't know how we solve, I mean, if you solve it with box 10, I don't know.
No.
Or
It's
how you
really to
solve it.
find out if they have been referred, or do they want to be referred? That's kind of just
And
to.
if it helps protect the centers and the health plans, because there's been some due diligence, and this is what CMS or the counties want, then we should think about that. But
Yeah, and part of our care coordination requirements in that APL that I referenced earlier, there are some checkboxes around mental health that we should incorporate in here, and I'll
Right, some different ones, right?
Good.
Yeah.
Right. What the whole
Last
plans
next time
have
who's
is-
doing the management, actually, the medication
Right.
management for, you know.
Okay, so for now, we're going to flag
Yeah,
box 10
just
as
flag
something
it.
further
Right. I'm just
conversation.
saying it's
Can I make
Okay.
one more note on this? This,
it's a policy issue.
this box doesn't really distinguish, it says primary or secondary diagnosis of chronic mental illness. And therefore, it has caught up everybody in
You're
this
right.
net,
You're
including
right.
people who
Good
just
point.
had this sideways diagnosis of depression made by their physician
Right.
that, you know, actually they are fine.
I think this is actually the way the regs are written for the included and excluded diagnoses under the short Doyle. So I think that that's part of it.
Oh, 1830,
Right,
We
right.
We can
But
look
to
that
get to
up.
the issue of coordination, if we use this box for something like it, for coordination, that would be a different issue.
Okay, so we got that flag, primary and secondary as well. Okay, moving on, box 11, ADL, IDL limitations. So, so we heard earlier from Lydia that at least you guys have, in some of your work groups, been talking about, you guys like this as any big issues, but is there an improvement we can do to this box based on the anchors that you guys are working with in TOPS?
I mean, I can share those, they're just a verbal, you know, in a written description.
Right, but like I've had this conversation, maybe even with Amanda, and I've had it with a number of my managed care plan contacts that talk to me all the time on the email and everything, is that, well, how do we look at these definitions, and what if there's a different definition at a different point in time with a different clinician and all of that, and so I think that to the extent, because all we really have to work with here is what we've put in the language here.
I think for this, it might, how we can solve this maybe will be with some instructions that are more clear about, you know, is it your best day, your worst day,
right?
Today, this moment. You know, with IHSS, they ask the person on your worst day, you know, how do you rate yourself on blah, 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 blah.
Is this necessary on the IPC? Is this information, and I get that I get it from other ways, but so do you manage care? Do you need to see this?
We look at that a lot.
You
do.
do.
Okay, it's all about function.
Yeah, gets to eligibility though. Yeah, that's a different.
You know, we've got sometimes what, and this is what happens too, is that you've got a PT who's assessing the participant, you know, on the same issue that maybe the RN is assessing the participant, and maybe another discipline is assessing, OT is maybe assessing the participant, and there might come up with different answers, different views, that kind of thing, and that's where this was another little catch that got us a lot of people into trouble under A&I, is that there was a discrepancy. So this is information that is on all the assessments. So this information is gathered during the assessment phase and then transferred from the assessment to the IPC. If this is information that the managed care needs, that's one thing. If it's not, I would suggest that having it in the assessment process is a necessity, but having it on the IPC may not be.
But then, okay, but I'm going to take your observation, though, and question again. I don't do guide, I'm DT, so I'm kind of an observer, right? So then the audit comes from the health plan, because they've got to send, you know, they have to do audits once in a while, and they see 3 different assessments that all rate somebody differently on ambulation, and there's no conclusion of how those 3 persons have agreed that, okay, we're going to rate them as need supervision versus, you know, dependent. Doesn't that create more of a problem than if you have arrived at a conclusion in one document, though?
Yes. So at the MDT, we discuss if there's a difference of opinion. We discuss and reconcile and document why there was agreement on the plan.
Oh, okay. And I like the words, because that again brings us to the functional issue. So if you're saying that yours has words instead of checkboxes as to what is the level, that's so much more clear.
Well, I'll share and we'll see if that makes
we
sense.
can integrate words into that, which is going to be way, way better.
I'd just like to also bring up that I'd like to revisit the issue of queuing, because this has been an argument over the years as to supervision would include queuing. Needs assistance is physical help required, and I think that there's some differences out there in how we look at that. That verbal queuing is
That's a good idea.
Okay. Moving on, box 12. So current assistive and adaptive devices. So again, we're still in the iteration of the IPC where we gave a lot more background information about the participants to describe their sort of functional levels, what other services they're getting, et cetera. So whether any of these need to be adapted to changes, that's something we should consider. The competence information, again, we got down in the last, the previous one iteration before this last one, where we talked about the nature, was it occasionally, frequently, always. We got a little bit more detail in there. That was an improvement, but is there other improvement that we can look at there? Feeding information, again, we got much more detail a couple iterations ago. The support services, this is, I'd say it has always been sort of a controversial box, because from the provider's perspective, we always hear, well, we don't know. We don't know this until after the first 6 months, not at the initial. So whether they have various other services in place, sometimes it's not known until later.
So Denise, this is real quick. I'll go back just up one line to the feeding information. There, maybe we can make a note for next few discussions about maybe substituting some of that with just a BMI score, for example.
Okay.
Because that tells you about underweight, overweight, and then you have a number,
Something
and then you can
measurable.
do something with the number.
I like it.
Yeah.
And again, can I just, for the question of do we need, I just wanted to trigger that we want to think about in this IPC what kinds of fields we want to track at a statewide level.
Exactly. It's the only statewide
It's tracking is
So that's
all a measurement
It's
issue.
tracking.
It's just part of what we might consider as we go through this. Is this something that we want to be able to have a staff on?
If we're going to look at acuity, we're going to want this information because the BMI will tell us.
Okay.
So this is, so yeah, just say Amanda's tracking. Cool.
Well, no, I was just saying instead of having overweight and underweight, maybe we just have a
Oh,
number.
sorry, I didn't hear that.
Yeah,
I just
have a BMI number, then you can.
So if we're interested in these being tracking, if we're keeping them on primarily for tracking, and or here we want to keep them on either for tracking or because managed care would like to see them.
Right, because it's the only statewide.
Right. If it's just cool.
Yeah.
So if we have if our reasoning to keep it on is tracking, then let's look at making it very, very trackable. Like Lydia just said, overweight, underweight is not as trackable as BMI.
Yeah.
So let's look
Absolutely.
at the function of.
And please look at any and all of these fields as having that capacity in this IPC, because when we talk about, like when we look at revised the last participant characteristics report, at least for the software vendor centers, that most of the changes were pulled from data on the IPC. So the software folks programmed it so they could pull it directly from the IPC and put it into IPCR. So if you have a BMI score, now we have something to
Way cool.
Okay. Yeah, and I just had heard Lydia, if I confused things.
Okay.
I couldn't quite hear.
Okay, so we did box 15.
Just a quick technical update. I'm communicating with Linda Jeffrey, who is on the call.
Oh, good.
She's only in listen-only mode, though. She's not able to participate on the webinar.
If she types something, we can't read her comments.
I don't think
you guys see her.
It doesn't sound like she's able to participate on the webinar.
Is she not? Did she not go
She
online?
couldn't with the link.
That's why. So she can't type because she didn't get online.
Yeah, I don't see her name here.
Okay,
She's
she's
on.
on.
She's on. Well, she'll do it through you.
Yeah.
So does she have some comments to make?
They've already gone, so we're going to take a look at this together and then just continue.
Okay, great. Thank you, Linda.
Pipe up.
Yeah.
You're in a little
She's
emoji.
quiet. So if you see me right here, it's not
Selena,
gonna-
yeah.
Okay, box 16, I guess I would just say this is within the last 6 months, the participant has received the following non-institutional services. I think it's a great, again, this is a great thing that we can capture if we wanted to. There has to be a will among all of you, but if it's on the IPC, we can capture a thing like ER visits.
And that's, we do that at the center, and if you look at our IPCs, there's a running tally of dates. And so every time the IPC comes up, the nurse just adds the next dates.
Yeah.
If there was an ER visit or any of those
That's
items. And actually, I don't, is that the hospitalization? Is there another one? No, there's home health.
Is it down
Scroll
below?
in there, scroll down a little bit further.
Hospice.
There's
other
emergency
Anyway,
department
it's
visits.
really valuable. And so to create a document where it's an ideally electronic, where you're capturing those related dates.
Yeah.
And the related
So-
reason for is.
So including dates might be something in this field.
Yeah, you don't just have one hospitalization.
Like
you have
TOPS
hospitalization.
captures it right now, so you can have a summary report that says these many ED visits, these many hospitalizations.
Yeah.
What if we remove, if it's for tracking, what if we remove all the explains and just have the checkbox and the date, or the dates of? Because
Or the number of.
explanation because the explanation is going to be in the chart.
Yeah, it's a good way to think of it. Yeah.
So duplicating that.
I would think, because the plans, when they look at stratification and all their algorithms, they're not looking at narrative, they're looking at numbers.
Yes.
Yeah.
That's a good suggestion overall.
Yeah.
Okay, moving on. Risk factors, box 17. So I remember the epic discussions about this in this very room during 1755 discussions. So the risk factors that we have listed now, I guess the only thing I would just suggest is that we rethink, are there any other risk factors that we want to add to this list, something that's not as fruitful to collect, and again, remembering that we can collect these stats statewide if we want to.
Well, we could look at social determinants of health, and we could also reflect health literacy.
Yeah, we were the ones that wanted this box because otherwise the field offices weren't getting it. Oh, everyone is a fall risk.
Yeah.
No, they're not.
Is this a catch though? This is a catching, this is potentially, so I like it because I think it's good information. We've got to change dementia-related behavioral problems. That's not a terribly person-centered statement.
Okay.
An inappropriate affect, inappropriate is not probably a very person-centered word. So we can look at, what was the reason for that? Is it, what was that trying to get at? Anyway, this one can be problematic in that I like it, I want to keep it, but just bringing up the, what is poor judgment? Do we have some real explanations around that? And that, again, may not be terribly person-centered conversation.
The cognitive impairment issues that Ruth brought up.
Yeah, right. So there might be a better way of explaining what that is as opposed to, someone who chooses not to take their medication because it makes them feel sick. Maybe somebody's going to say, oh, that's poor judgment or non-compliance when it's participant choice. So we've got to be really careful about that being a judgmental.
So maybe looking overall at the subjectivity of all of these things.
Absolutely.
Yeah, they need to tie back to measurements.
Yeah.
I guess I wonder, where does the health risk assessment maybe coincide with the risk here? Because you're doing that stratification, and what are you basing your health risk? But they may have relevance to.
Well, every plan has a different HRA, right?
Yeah, we have different HRAs, but they're all approved by the state.
Right.
And we can maybe bring
core elements.
Yeah, there are core elements, and that's also a pretty lengthy document as well.
I know.
40-ish.
I know.
Yeah,
And you don't get it on everyone. Not everyone wants
No,
it.
exactly.
That's
They don't have that's a challenge. It's difficult to get for everybody.
These risk factors are very nebulous.
Right.
And they're not.
Yeah, I think we need to work on that.
I know that ours is based more on what that person says that they need versus, versus are you a full risk? I mean, do you can't ask them, do you have poor judgment?
Oh, yeah.
But, so we ask about if they've been to the ER recently, if they've been hospitalized, if they have a doctor they know how to access, if they have a DME, if they have a caregiver, if they have trouble paying their bills.
Those are the social determinants.
Yeah. Okay, sounds like we're going to spend a good deal of time in this box.
Yeah.
So we got this one flagged. We need to look at person-centered language. We need to look at measures for these things, social determinants, health literacy. Okay, cool.
Risk factors for.
Risk factors.
Yeah, that's right.
Well, you know what that was actually, when that box went in, trying to come up with a shorthand way of avoiding box 27.
Yeah.
Yeah,
Right. It was. Because box 27, by the way, doesn't exist anymore, but box 27 is now in box 23. But it was just supposed to be for additional information.
And everything else.
Okay, you guys, we've got like 7 minutes to get through the rest of this, or maybe a little bit longer.
18 step. This is where we are running record of
this is a great box. So this is at risk for admission to acute or institutional level care. So then we have in the last 6 months, acute care hospitals, nursing facilities, ICF, placement. So
I think we can probably combine, I think we can capture these things in one.
So collective is box 15.
No, I think this is what's happening. Yeah. That's how long I've been.
Okay, hang in there. We're getting there. Box 19. So we are now getting into this is more attestation stuff. This is back to what of those core daily services that you're required to provide every day are you doing? And then the answer is if you say no, you're not meeting the criteria. So it's kind of a perfunctory and takes up a lot of space.
It's a gotcha.
Okay, it's a gotcha. So one thing I guess I would point out in box 20, and maybe we can find a way, I think this was something Diane was talking about earlier, when you've got somebody who you've stabilized, they had past history of all these hospitalizations, and now they're here, and you guys have them stable. This is actually straight out of the statute. If there's a reorganization TAR, the participant's condition will likely deteriorate if CBAS services were denied. So that's in the statute, and maybe we can think about box out a little bit and increasing some kind of background information that says why, even though they're stable and all the goals are the same, they were met and continued from the last time. You know, something that gets in, because we also have to get at progress for the new federal requirements in 96C. So we have to talk about progress achieved, and that was in the previous, you know, few IPCs back. So maybe we can look at this as being part of that discussion.
Yeah, I think that's a good idea.
If this one could be at the top, I think this one should be at the
For
very
REOS.
For the REOS, at the very top of the IPC, because this is so important. I think it just gets lost in the shuffle there.
Okay, got it flagged. Box 21. We have, so now we're in the care plan, finally, after 9 pages.
Finally. That's right.
In the care plan. There's a lot of stuff.
I'm filing all this stuff.
It goes to, this is like it's been what we call the Winchester Mystery House, you know, the IPC, when I first got here in 1992, it was 2 pages long. And it's actually 4. It actually had the goals and, the progress on the goals, too. So.
I have a sample of one of those old IPCs.
Yeah. Maybe you should bring it back.
Yeah, bring a scan. It was the model given us by CDA when we were first opening.
Yeah, no way.
Scan it.
Yeah, I share it with the group.
I saw an older one that was over at the LRCAP, like, and because they're really old, like, I'd never seen one like that before.
Yeah.
It was way,
They're neat. They're artifacts. Yeah. So box 21. This is where I think.
I have a question before we move on to 21. I don't see transportation in here.
It's not.
Okay.
Isn't that weird?
So I know that
It
it's
used to be.
you know,
It's not there
provided,
now.
but I run into instances, and I'm not sure if you have, where transportation isn't adequate or appropriate, the level of transportation that a participant needs. So, for example, wheelchair, a center not having a van or a vehicle that's appropriate for wheelchairs.
So you mean their transportation to and from the
So there
center,
are needs.
not in the community?
Correct. To and from the center.
Okay.
Wouldn't it be the
Yeah,
same?
I mean,
I don't know.
no, because
No, it's
transportation was pulled out of an IADL, or is it still?
No, it's not in.
No, it's not anywhere.
It's not talking about.
It's talking about how do they get to and from the center?
right.
That might be good.
That went away.
I don't remember.
But why, since we're required to get in there?
Right, but not all centers have
But we're not,
the level of transportation.
we're not required to get them, we're required to arrange for it.
Right, but she's saying that from the plan's perspective, they would like to know what's happening with transportation.
Right,
Yeah.
is the center able to meet the transportation needs of the participant, or is that something that we need to help or partner with the center?
Oh, yeah, that goes in that community.
Yeah,
So, I mean,
it's on the
we-
list of what the IPC is supposed to include.
Yeah.
I did.
Is transportation needs included.
Yeah, we had a conversation.
It's missing.
You're right, Selena, good catch.
It's not.
Yeah, that's very good.
Yeah.
And our plan has participated in arranging transportation for folks that we can't get to with our vehicles.
Right.
Partnership has.
Okay, great, got it flagged. Okay, so 21, I guess I just wanted, because we had a placeholder sort of for the discussion about, do we want to look at, as we get into the care plan boxes which are 21 and 22, that's the bulk of the IPC and most important part. Do we want to look at reconstructing it so it's more IDT model, where we're talking about what are the main problems that the participant presents with, and then the disciplines intervening on all of those problems or needs, or do are we interested in entertaining that, or do we want to stick with the disciplinary?
Yeah, we have providers here, so we can monkey around with some ideas and try them out, and because we're going to have to live with what we come up with, so let's see what's out there.
Okay, so I will say the group is open to that. Okay.
And
so Laura Conley, our director, just came in, and we'll just wait for her.
My apologies, I really hoped to be here earlier in the day, and it's just turned into kind of an unusual day.
Also,
It's my attire, it's our agency charitable kickoff day, and we have to do different things for our agency, so I am a hippie.
Hippie win, romance. Hippie win, that's all I want to
Anyway, we got an honorable mention for extremely creative cookies.
Right on it. Okay.
Oh, cool.
Oh, nice.
Okay, great. So we're doing the anatomy of the IPC right now. This has been a very productive work group. Okay, so I'm just making a note that we're going to think about redoing in the IPT kind of format, main presenting problems, right?
Yeah.
Needs. I'm ready. I'm sorry.
Needs and preferences.
Needs and preferences. Okay.
Can we look at the word needs?
Sure.
Because I get the negative connotation of problems. What else could you use?
Well, the measurable, I'm sorry, go ahead and finish.
You might have been right me there. I mean, because needs doesn't sound right to me for some
It's
reason.
not clinical
Not being clinical, but needs is like who is it? Something that is needs seems almost directive.
You want to say desires?
Concerns, barriers, concerns.
It's only federal
an area of
stuff uses
improvement
needs.
needed.
It uses, yeah, support needs. What else does it
I like
use?
concerns.
Working from what you were describing before, Amanda, some of your thoughts, and I'm wondering for the plans. We have assessments with measurable things in them. We create care plans with measurable aspects. But when it comes to what we describe to you all, do you need to have it down to that level of detail? Or could we do more of a narrative, even if we were doing it discipline by discipline, something that would be simpler but would be getting, something about challenges with the participants' blood sugar and their, working with diabetes or whatever, more of a care management statement, let's say.
I know, I almost think that what we want to see for establishing medical necessity for a number of days that person needs to come.
That you need that.
It's almost different than what the IPC would be used for at the center. Because what the IPC is going to be used for at the center is much more comprehensive, and how the center is going to collaborate with that person and help that person. And what we want to know is what that person, why that person needs the center, and also, yeah.
How many days?
Yeah,
that's what I was
need
trying to
And
figure
how many
out.
days do we need?
Yeah.
It's based on how many days do we need of services per week so the participant will achieve the goal that's been identified.
Right.
And we need to have our interventions be very clear, I think, because that determines the care that we provide on a daily and provides the staff with a roadmap.
We have a number of interventions that we must provide every day, but do you need to know our nursing care plans on the IPC go on for pages?
Yes, right. And do we need all of that?
Yeah.
That's a really good question.
Unfortunately, we didn't start with that at the top, because that really is a huge part of this conversation, is all the different audiences for this IPC.
Yeah.
Because we use the IPC too, but I'm not monitoring.
And maybe that's part of the problem, is trying to meet everybody's needs, all the different parties' needs through this IPC, when it could be like an IPC for the center and the member, or the person, and something that tells the plan what the plan needs.
What we've always dreamed of is having some predictive data elements that could get translated into both, need as well as days, right? I don't know if we can ever get to that, but I wonder as we go through this and walk through it a couple more times, if we begin to think about, especially those of you who work with the IPC, I don't, Denise doesn't, but are there some specific data elements that already reside in the IPC, or maybe some simple ones to add as we take things away, that are predictive of need for days? Is it certain risk factors that have been measured? Is it function? Is it behavioral health conditions? Is it dementia? Well, there might be some simple things that if you added them all up would be like, voila.
as well as therapies or whatever, PT and OT. I mean, if you have someone and they come in and we say, oh yeah, 3 days a week should work, but then they have PT and OT and speech all 3 days that they're there, they're so slammed by the third day that they barely make it through the weekend kind of thing. You know what I mean? And so making that function, 5 days, I mean, depending on the frailty.
And yeah, and right. And when we look at them, we really like to know what kind of help do they have at home. Maybe they get IHSS hours, but the IHSS caregiver can use those hours anytime they choose. So maybe the daughter's the caregiver, she works during the day, and she uses the in-home support service hours to provide care at night. Well, that person's still not safe at home during the day.
That comes under the narrative, the big picture. That comes back to the narrative of drawing, because I used to say that the care plan to me was a skeleton. And the narrative was actually the skin and the bones that filled it in. The skin and the muscles that filled it in and created this human being in front of you. And that's what I think the narrative is for. I'm not sure that you said something that I really liked, and now I can't remember because I lost my train of thought.
About people being service from too much service.
Oh,
too much service, or how do you?
And I think that has to come into potentially in the summary box too. If I think one of the issues we had with the summary box is I love the summary box, by the way, and.
Yeah, but if you have 140.
I know, no, I'm with you. And I get why it was, I don't think it was read a lot. But if we now know that it will be read, and potentially if we can write a good summary that tells the story of Mrs. Jones, gets PT and OT 3 days a week, but she really needs that socialization time, and she needs the extra time, and she needs the activities and the social services on the other 2 days. So instead of trying to fit everything into these 3 days, although they might only need something 2 days a week, they can't have it on the other 3 days. So you really want 5 days per week. The only way to do that, I think, is to do it, through the summary box. But that would be a great way to explain, why you need 5 days a week, even though you're providing services, and so you don't have Mrs. Smith getting 12 services 1 day a week and she's frail.
So is that a challenge when you're reviewing these days? People are asking for 5, and you're thinking, what?
Right. So the detail in the summary is helpful. For the case managers.
And do you ever reduce the days that the provider is requesting?
Yes.
Yeah. You do?
But much less now than we did in the beginning, because the providers, I think, understand now. They have a working relationship with the nurses.
Yeah.
They understand kind of what Anthem's looking for and what we're not looking for. And a lot of the times, maybe the nurse will be out there, maybe she'll be at the center, or maybe she'll just call the center and say, look, I don't think this person's going to meet criteria for 5 days a week, and this is why. And then a lot of the centers will just say, okay, well then I'll request 4. So a lot of the times it'll be an informal process, but initially it was very.
It has been an age-old problem.
It has.
Well,
really
we try, like Amanda said in reference to, we try to put in our narrative what our concerns are, or what that person, we have one person that it takes her minutes to get to one of the therapies or whatever, and because she eats lunch so slow that getting her to her next thing is. So, and explaining all of that piece of it is kind of making it.
And if we're going to allow the flexibility, like you're saying, so and I'm sure Beth and Lynn probably want to do this too, is if we have flexibility in their schedule, this goes way off to the other side, but there's people who are feeders, we call, it's a terrible word, but feeders, and you feed them as, I know, I'm being,
we don't like to hear that word.
I'm being non-person-centered. Specifically, on purpose. I got issues with the word wanderers, so I certainly have issues with feeders. So, if you've got somebody, we're going to call them a feeder, and you're feeding them as fast as possible, right? They're a feeder, you put them on the feeder list because they eat slowly, as opposed to allowing them the time to eat the food, because maybe they can eat the food on their own. But they just do it really slow, which is perfectly appropriate to allow, instead of putting them on a feeder list and force feeding them. Allow them the independence to eat for themselves. But it might take 40 minutes, 50 minutes. It might put your staff out of, their comfort zone. And that's person-centered. So maybe that's in part of the narratives that we're doing too, is that, really explaining, we want to allow Mrs. Smith to eat her food, and she takes 45 minutes, she takes an hour and a half to eat her food, but she remains independent in eating because of this.
So to be respectful of everyone's time, and that's okay, and to play the role of facilitator, I want to just sort of recap a couple of things and tell you all where we need to be by 3:30. So I have flagged that we got as far as box 21, and that we're going to think about looking at the IDT kind of format. And I've also made many notes about box 23, which is the text box. No longer something box 23 box. It used to be 23. And this will be for conversations next time. But I basically said that we all seem to like it. But how could we make it maybe more useful in capturing for the plans, for the centers, some of those additional reasons why somebody needs to be at CBAS. And I also flagged for next time for discussions, because that is the rest of the agenda. We talked enough about overlapping issues. As far as items for the next meeting, I wanted to just tell you that I captured level of care and level of care determination as being one of the important things that the IPC might need to be addressing better, maybe through the text box and
when you say level of care, is that days?
That's the days per week. Sorry, levels of care. Or levels of service determination. Yeah. So I've got that flagged as something that we might want to consider. Also, maybe at next meeting or in between that we'll talk about is the many different audiences for the IPC and how we need to consider who needs the IPC and for what. I've also got flagged, I don't know if anybody had this thought, but when you were talking, Amanda, about HRAs and maybe we need a little presentation on some of your HRAs. That might help us in thinking a little bit about the IPC, some of the things that you guys are doing at Anthem and HealthNet, and maybe even LA Care will be in next time.
Or will be elements.
Yeah, some of the core elements or
website,
things that you think might be helpful for us to know about as we look at the IPC revision. So I flagged a few topics for next time. If any of you have, we'll invite you to give us agenda items for the next meeting. But in the last few minutes, what I wanted to just talk about is based on our conversations today, does anybody have any sense of any in-between work we can be doing, any homework we can be doing to give ourselves a running start for the next meeting? Is there anybody who's interested in perhaps, if you would pull up, Lynn or Lilith, pull up the tool that we were looking at earlier. You guys have it, we gave it to you earlier. The tool that we have for the IPC for looking at the crosswalking. Are we ready for doing something like that? I'm kind of feeling like after this conversation today, I'm not so sure.
Well, I think we can, yeah, I think.
You think we can do something like that? So if we were to try to do this, should we do it like, should we look for a small group of people who are willing to do that, or should we maybe CDA kicks it off and routes it around, and we have we don't have a Google Docs or anything like that set up, but maybe we
do
could.
actually.
Oh, we do?
Have a Google account or Gmail account.
Do we? Okay, so maybe we should look at doing something like that where we can get everybody's input on that. I mean, what do you guys think?
I like that.
Like a small group, or you guys could kick it off, whatever. But
Yeah, we could all add to it in different colors.
I kind of like to be able to map out what's absolutely mandated because it's in the document.
Right.
We can't get around it, but we could figure out a better way to ask the question maybe.
Right. That's what I was going to say. My homework is I'm thinking of that APL or care coordination requirements that will fit really well.
Right.
with
Okay,
these.
well, that's the next time too.
Yeah. Do you want me to look for the core HRA, or do you think you've got your hands on it? I'm pretty sure there's
The core HRA.
the core elements, maybe at CMS level. Do you want me to browse
I do
after
have
that?
that. I don't
Because maybe I can ask Amber too, because
okay.
Justice and Aging has been tracking all that stuff, so I'll take that responsibility.
Can you bring in your tool too?
I'm going to bring in the behavioral anchors for ADL, IDLs.
Maybe just email them.
Sure. And those are all on tops now too. So.
Okay. All right. So I think maybe what we need to do in to be cognizant of the time and everything here, is that what we'll do is we'll route around, let's just say, a list that says, these are the take-home sort of ideas that we had from this meeting. Because we talked about both all of the things that are required by the feds for this IPC and then all the things that we seem to want on our wish list. And so maybe what we'll do is we'll kick off the work tool and we'll say these were the other items that we identified for in-between meeting or next meeting topics. And then we can get whatever things that you guys have on your list that we missed.
Was there a sample IGT care plan that we could?
We haven't?
So what I was thinking about too is IDT. So what I was thinking about is I can create kind of the idea that I have, and I also have like I built a participant, and she's a summary. So I could bring in kind of the summary of this participant and like an example of an IDT that might be built from, a vignette.
Okay, so how about maybe for routing actually in between meetings? Sure. So I think the more things that we can get going in between and thinking about, that'll help us shape our next agenda so we can actually start.
I'll send out one.
Do
we have a next date?
We don't. So
let's question whether it's December.
Yes.
November doesn't make sense, or January.
Yeah, so that's part of the challenge here is that the timing-wise, November feels impossible to us. December is undesirable. Early
December maybe.
And it sounds like you guys were all, it's the end of the day. Are you still all for the all-day format? Did this work for you? You were here all day? Okay.
Hardcore, yeah.
Okay.
Overachievers.
Okay, good. I like it. Okay, so we'll stick with this. So then the question is, do you want to try for December, or should we wait till January? If we wait till January, we definitely have to do a bunch of things in between. I don't know. Or we can kick around some date opportunities and survey monkey you all.
Yeah. Early December.
We can do early December?
Yeah.
Yeah, January just feels so far away.
It does. I know it does. I know.
And then so far around. We're getting to that.
Yeah, exactly.
After Thanksgiving, before Christmas.
There's a little window right there.
Okay. All right. Okay, so we'll look at some dates first 2 weeks in December then. Are Wednesdays generally good days for people?
Sure.
Yeah.
Wednesdays are good. If there's nobody coming in from LA, and that's not a consideration of time, it's difficult for me to get here early. Like there'd be like childcare issues and stuff.
Right. So you have the afternoon for IPC.
Yeah. I mean, unless unless there's somebody.
And nobody else has expressed. We were just talking about flipping them just for the heck of it. But if there's a strong preference for IPC in the afternoon.
I know Sheila can't ever make the afternoon because she teaches, so I know that she would say, can we switch, but.
Okay, yeah.
I would say that.
No, it's because of the time. It's the same thing.
If we're going 9:30 to 3:30, would 10 to 4 possibly work to get some of this?
10 to 4 is fine.
10 to 4.
Works for us. Anybody?
Gives you more time in the morning.
10 to 4.
So a little bit more traffic.
10 to 4.
Oh, because I'm driving. But if you get more traffic, then
Right.
Yeah. And
Is that a deal breaker for you, sir?
Not a deal breaker.
Okay.
I'm the only one.
Okay. Great.
And then Denise, are we going to do a document on audiences? Do you want to work together, you and me, on maybe
Document on
audiences and needs, maybe kind of thing? I'm picturing we could kind of figure, it would kind of go along with the mapping, but.
Yeah, I can do that.
Yeah,
That's
I can
the
work with you on that.
module approach, the module for the module audience. When you were talking about the module.
Oh, that's different. That's layered on top of that. The different audiences that use it, and then the concept of a modular.
Yeah, that would kind of lead from that.
Yeah. Okay. So it sounds like we're going to send you a splatter of all sorts of things.
Oh,
and you guys react to it.
But
and
Google
start
Docs
narrowing it down.
site, Lilith, if we could do a Google Docs site, we have one that would be nice. We have one. Whatever.
Yeah, Google Docs. Yeah.
Expert, yeah, you and Adam, but, right?
He's giving you the thumbs up.
Yeah.
He's on still with us right here. On it.
All right. Are there any comments from anybody else on the webinar that out there? Okay, then let's wrap it up. We're 2 minutes late. Thank you, everybody on the webinar, for participating. Everybody in the room. It's been super productive. We got it started. Yay. Thank you very much.